it's 4 p. Ma'am, go ahead. Yeah.
Good evening, all. I welcome you all for day 3 of this ICOG Foxy Certificate course on midlife. And I would like to introduce the convener for day 3, Dr. Rajan Nagakatti. Dr. Rajan Nagakatti has been the Honorary Treasurer, Mumbai Obstetric and Gynecological Society. He has been the past Chairperson, Foxy Midlife Management Committee, past Chairperson, IMOGS Midlife Management Committee, and the Founder Secretary, ESOPAB. He has been the President of the Obs and Gynae Society of Mira Bayandar, and he has many positions which he has held, and he's consultant obstetrician and gynecologist and IVF specialist at Ashirwad Maternity and General Hospital, Mira Bayandar, Mumbai. So I welcome sir and ask him to take on. Welcome, sir.
Thank you, Aditi, for the kind words. At the outset, I wish to welcome you all to this prestigious Foxy ICOG certificate course on midlife management. I wish to thank, am I audible?
Yes.
Yes, sir.
Okay, thank you. I wish to thank the team ICOG, led by ICOG Chairperson, Dr. Parag Biniwale, the ICOG Honorary Secretary, Dr. Sarita Bhalerao, ICOG Chairperson-elect, Dr. Sheila Mane, ICOG Vice Chairperson, Dr. Ashok Kumar, ICOG Vice Chairperson-elect, Dr. Sadhna Gupta, Madam, and the entire team of ICOG for convening this workshop certificate course on midlife management. And I wish to thank you all for inviting me to be a part of this as convener of day 3. I welcome you all on behalf of my co-conveners, Dr. Anju Soni and Dr. Archana Dwivedi. At this point, I would like to say that we have with us Dr. Sarita Bhalerao and Dr. Sadhna Gupta. So I would like to request, yeah, please share the, yes, just a minute. Yes. So I would like to now introduce Dr. Sarita Bhalerao. She is a consultant obstetrician and gynecologist at Bhartiya, Saifi, Reliance and Breach Candy Hospitals, Mumbai. She is the secretary of the Indian College of Obstetrics and Gynecologists, ICOG, immediate past chair of the AICC RCOG West Zone. She's been a president of the Mumbai Obstetrics and Gynecological Society 2021-22, past president of the Association of Medical Women of India Mumbai branch, and also past chapter secretary of the IMS Mumbai. We would like you to please address the gathering and please give your a few words. After that, I would like, first, I think we'll go to Dr. Sarita Bhalerao.
Thank you very much, Dr. Nagarkatti. And I welcome you all to this ICOG certificate course. And at the outset, let me thank our President Foxy, Dr. Sunita Tandurwarkar, for being so supportive and encouraging us, and Secretary General Dr. Suvarna Khadilkar. A lot of work has been put in by our conveners, Dr. Archana Dwivedi, Dr. Anju Soni, and Dr. Nagarkatti, and I congratulate them on organizing this course. And also, I'd like to mention our coordinators who've done a lot of work, Dr. Reshmi Banerjee, Dr. Madhumita Arun Karthik, and Dr. Aditi Rathor. So I think it's going to be a great evening. Today is our last day of the certificate course. Next month, we have another certificate course, and this time it's on oncology before we end our certificate courses for this year. I also take this opportunity to remind all of you that today is the last day to register for the FICOG. If you want to take membership or you want to take fellowship, today is 31st October and it is the last day. You can still register. And in case you cannot register today and you want to register after that, then you can log on to icogonline.org and register for the next convocation, which is going to be in Bangalore in the month of August 2026. So with that, I welcome you all and I request Dr. Nagarkatti to proceed with the course.
Thank you, Dr. Sarita. We would now like to have a few words from Dr. Sadhna Gupta, Vice Chairperson-elect of ICOG. So, Dr. Sadhna Gupta is, yes, as I said, ICOG Vice Chair-elect for 2025. She's the Central Executive of ISAR, ISOPAB, SFM, and the Indian chapter of MFM. She was the Foxy
Aniki
State
Potter.
Motherhood Committee chairperson from 2011 to 14, founder of the founder president of the North Indian Gynec Forum 2022 to 25, and president of Gorakhpur ISOPAP chapter. She's also held positions, very important positions like Foxy representative to SAFOG from 2018 to 21, Foxy vice president 2016, UPCOG vice president 2025-26, co-chair of the SAFOG NCD committee 2022-23, and a chairperson of the UP ISAR committee 2014. She has various
Thank you.
awards and honors to her credit, including the Padma Bhushan Kamlabai Hospet Award, Dr. R.N. Malhotra, Dr. Duru Shah, Dr. N.A., and Shailaja Pandit Award for Distinguished Community Service and Maternal Health. She has various publications, and she's held key positions at various organizations. So over to you, Dr. Sadhna, madam, for a few words.
Thank you, Rajan, for very generous introduction. It's a great pleasure to welcome this certification course of ICOG, which is actually USP of our college, Indian College of Obs-Gynae. And congratulations and hearty appreciation to Dr. Parag, Dr. Sarita, Dr. Ashok, Dr. Sheila, and all ICOG team that we are regularly on the board, on the toe, and taking a very pertinent subject, which is important to every clinician. Hearty congratulations to Dr. Archana, Dr. Anju Soni, and today's convener, Dr. Rajen Nagarkatti, and Aditi, who is the coordinator of the today's program. So the midlife health is something which in current time we have to reorient ourselves because the aging population is the thought of the global health. And the world is struggling with the aging population, while the fertility rates are going all over globally, including India. And as a OB-GYN, we have a great role to play, that our elder citizen and especially women and their family are not only have the good life, but they have the good quality of life. So a great program has been crafted by Rajendra Nagarkatti and Aditi and all the conveners, and they have taken the every aspect of the midlife health. It is a holistic, it is a isoflavins, it is a the genitourinary syndrome, weight gain, which is something we have to rethink that what weight gain means in midlife health, and that is the thing that we have to really rethink, considering the Indian and South Asian population. MHT, FIGO have given latest recommendation on menopausal hormonal therapy, and Tibolon, again a review. I think Dr. Savita, Dr. Aarti, and Dr. Jyoti Jaiswal, who has been very, very active office wearer and person in menopause society, they will throw light that what is on and how we should be very, very careful in selecting the dosage and the drug for the menopausal hormone therapy. And Dr. Ragini Agrawal, who has been working very hard for the cosmetic gynecology as well as the menopause, she must be taking a very, very good case, which is actually in FIGO 2025, the cosmetic gynecology was something session which has the most controversy, including the VETOX session, that actually what constitute cosmetic gynecology and what is the uropelvic and the urogynecology, and a lot of questions about the newer thing, because how much we have really efficacy, and there has been the controversies, and as a college and Foxy, we will be doing all fresh thinking and all experimental thinking. So hearty congratulations, Rajendra, Aditi, for making this program very pertinent. We see Dr. Neeta Mishra, who has been the very dynamic figure for the urogynecology committee, and we look forward to their contribution. So it's great to have the seniors in ICOG with their a time and the precious time for sharing the knowledge. So we wish happy learning. Today, as Dr. Sarita said, today is the last day for the fellowship application, and that will be awarded in Delhi ICOG. And then if those who have been missed something, then we will have the ICOG convocation in the August 2026 also. So be a member and a fellow of Indian College of Obstetrician Gynecology. It is your college for the life. Thank you. Thank you very much.
Thank you, madam, for the kind words and uh, encouraging words for all of us. So now moving ahead, yes. So coming to the overview of day 3 topics. Uh, um, After the detailed discussions and deliberations on the day 1, which was on basics of menopause, lifestyle management, and fertility management, and day 2 on bone health, which is also very important, bone health, metabolic syndrome, and cancer screening, we now move ahead to the actual management part, which is on day 3, which focuses mainly on MHT and non-hormonal menopause hormonal therapy. Well, MHT, as we all know, is an essential part of the treatment of menopausal symptoms, and it should not be denied to our patients, especially if they are in the window of opportunity, which we all know as within 10 years of menopause, within 60 years of age, and with no comorbidities. So today we will discuss all these modalities, including oral MHT by none other than Dr. Jyoti Jaiswal, who has been so active in IMS. Uh, then Tibolon and its uses by Dr. Sarita Tyagi, a wonderful drug which she will elaborate more, and transdermal MHT by Dr. Aarti Gupta. Again, MHT may not be suitable for all. There may be some contraindications, or there may be some who are not willing or rather hesitant to take MHT. And for them, we have the non-hormonal therapies. And to discuss these, we have Dr. Hepzibah, who will be speaking on isoflavones, Dr. Darshana Shah, who will be speaking on holistic healthcare, And in this session, we also have Dr. Sarita Bhalera, who is speaking on menopause and weight gain, and Dr. Neeta Mishra, who will be speaking on genitourinary syndrome of menopause, or GSM as we call it. The last session is on cosmetic gynecology, which has taken rapid strides in these last few years. Again, is an essential part of treatment of menopause. So here we have an entire panel moderated by none other than Dr. Ragini Agarwal, who, as Dr. Sadhna Madam said, has done wonderful work in not only in menopause, but also in cosmetic gynecology. So she would be the right person to moderate this session. And we have an entire elite panel of for this cosmetic gynecology session: Dr. Krupa, Dr. Shivani Shukla, Dr. Binal Shah, Dr. Poonam Mishra, Dr. Riddhi Shukla, Dr. Jitna Vineet, and Dr. Tulasi Devi. Dr. Jamuna Devi also as panelists. So without much ado, I will like to go back to Dr. Aditi Thakur to take this forward and let the audience get the benefit of all these wonderful lectures. Thank you. I would also like to say at this point that I really wish to thank the coordinators for today's program, for this entire series, who have done a wonderful job in coordinating this entire event. One is Dr. Aditi Thakur. I think Dr. Yeah, Dr. Madhumita Karthik, Dr. Aditi Rathore, and Dr. Reshmi Banerjee. Thank you.
Thank you, sir. There is a short instruction of the on post test, sir.
Yeah, so I would like to read the instructions to all the participants about this post-test MCQ, multiple choice questions. So the thing is that attendance for all the 3 days is compulsory. Google link for MCQs will be sent in the chat box. Those who have attended all 3 days course and pass with 50% on each day, only they will get the certificate from ICOG. Certificates will be sent within 1 month. Now, please note that this online certificate course is just an acknowledgement for attendance. Practice depends on skill and experience, which we do not certify. So we do not endorse any skill of the attendees. The videos will be put up on the ICOG website in due course. For course material and equipment details, you may have to communicate with the course coordinators. Thank you. This message is on behalf of the chairpersons, the vice chairpersons, and the team ICOG. Thank you.
Next slide, please. I welcome you all on the first session on non-hormonal management of menopause, and we are welcoming our chairpersons. So we have Dr. Varsha Prapanna. She's a consultant gynecologist, credentialated menopause practitioner, past joint secretary and treasurer of Baroda Obs and Gynae Society. She has been president of Vadodara Menopause Society and has been the quiz convener in Indian Menopause Society national conferences for consecutive 3 years. Welcome, ma'am.
Thank you.
Then we have Dr. Suman Sinha, who is the chairperson, Vaginal Surgeries Committee, Foxy. Ma'am had joined us, but she just lost contact because she's traveling on a train. So when and where she'll get contact, she'll join us. And then we have Dr. Pragya Mishra. Next slide, please. Who is the consultant infertility specialist in New Life Test Tube Baby Center in MGM Hospital and Research Center. Ma'am is the president, Patna Obs and Gynae Society, and she is the Secretary General of ESOPAP 2022-24, 24-26 and ICOG Governing Council member 24-25. She has been the chairperson of Genetic and Fetal Medicine Committee, Founder Secretary Bihar Chapter of SR, and she has been awarded with many, many awards. So welcome, ma'am. Thank you for joining us. So I'll welcome our first speaker for the session, Professor Hafiza Kirubani ma'am. Sorry, ma'am. Ma'am has been the past president of Obs and Gynae Society of Southern India. She's the past president of Chennai Menopause Society, past IMS chairperson for Education Committee, joint treasurer IMS 2024-25, and she has developed the Midline and Beyond app, Preeclampsia Reminder app for mom, directed 2 short films, and she needs no introduction. She's a well-known figure for us all. So welcome, ma'am, and please go ahead with your talk.
My slides are seen. Hello.
ICOG.
Am I audible?
Yes, ma'am, you're audible, but your voice is breaking.
You're able to see my slides?
Yes,
No,
ma'am.
we are not able to see.
Yes, ma'am. Now they're visible,
Yeah.
but your voice is not very clear.
My slides are seen, ma?
Yes.
Yeah, let's see.
At the outset, I thank the organizers, ICOG, the entire team, right from Foxy President and Parela and our entire team, Sadhana Madam and Sarita Parel, and the conveners, Dr. Rajendra Katti, and then the coordinator. And my topic is role of isoflavin. So when this topic is given to me, I thought few questions came to my mind. What is its source? What is its mechanism of action? What are the effect on menopausal symptom? What is its indication, contraindication, the dose and the safety? What are all the evidence? What are all the limitation and consideration? So the isoflavins are nothing but a plant-derived phytoestrogen, and it is in soya beans. And the isoflavin consists of primarily genistein, diaxin, and glycine. So when we look at the source, the main source is soybeans and wheat and rice. It is available in herbs also, garlic and parsley, vegetables like beans, carrot, potatoes, in fruits like dates, pomegranate, cherry, apple, and drinks like coffee, whiskey. The highest content are seen in the nuts and oil seeds, flax seeds, followed by soy products like tofu, cereals, and breads. Soy is the richest source, contributing 60 to 70% of the isoflavin. 1 gram of soya beans provides 2 to 4 milligrams of isoflavin. So when we look at the this thing, isoflavin, it shared a structural similarities with the estrogen like 17-beta-diol, which can bind to estrogen receptors, especially beta ER, and these compounds therefore exert a weak estrogenic effect. When estrogen levels decline in menopausal women, this isoflavins can bind to estrogen receptor sites, and thereby it can reduce the menopausal symptoms. Isoflavone have a selective estrogenic and anti-estrogenic effect also. So the mode of action, it is little complex and it appears to depend upon the body's natural estrogen level. During high estrogen states like perimenopause and premenopause, it acts as anti-estrogen by competing with body's estrogen receptors. When the estrogen levels is postmenopausal, when it is low, that effect becomes more prominent and providing estrogen-like action that can help to balance hormone fluctuation. So the action at cellular level depend upon the target tissue, receptor status of the tissue, and the level of endogenous estrogen. And the recent studies, they have concluded it exerts anti-estrogen effect on breast tissue, but estrogenic effect on endometrium, and it acts like some selective estrogen receptor modulator. So coming to the absorption, isoflavone is absorbed readily and circulate in plasma and excreted in urine like any other thing, but it is fat soluble, but it is to become an active metabolite, a potent metabolite called equal. It depends upon the gut bacteria. The absorption is influenced by gut bacteria, but not all women have necessary gut bacteria to produce this potent metabolite. That is why there is a variation in the response in different ethnic groups. And Western women will have only 30 to 50% of equal producer, but Asian, they have 50% of them have equal producer. So coming to the potency, the isoflavones are not bound to serum protein, hence small quantities are sufficient. They have a greater potential because it circulates in the circulation, not attached with the protein. And 50 milligrams of isoflavone is equivalent to 180,000 picogram per ml of ginseng in serum. So even a small amount is quite efficient. And potency of ginseng is when compared 0.001 to 0.008 is equivalent to 0.5 milligrams of estrone and 1 milligram 17 estradiol. So a small amount is itself is sufficient. So when I looked at it, why we need isoflavone? Because the safety concern of MHT revolved around two main issues. One is when the extended use of MHT may increase the risk of breast cancer, and MHT may increase the risk of heart disease also. So the isoflavones have gained popularity as an alternative treatment for menopausal symptoms. So the indications are for menopausal symptoms, but it is not a replacement for MHT. And those who wish to opt for natural products, we can prescribe this. But those who have to stop HRT because of so many other reasons, we can try this. So when you're coming to the pharmacological action, it is multifaceted. It is an anti-inflammatory, antioxidant property it has. It binds, as I already told you, the estrogen receptor, exert both agonist and antagonist effect. And the recent research has also underscored that potential in preventing bone loss, and it reduces cancer risk, exhibiting anti-obesity, anti-diabetic effect. So the isoflavones are a key bioactive components in the management of menopause. It touch upon everything. So coming to the potential benefits for menopause, the multiple reviews and studies suggest that the isoflavone, especially the genistein, can reduce the frequency and severity of hot flushes and night sweats. Some studies shows significant improvement compared to placebo, though often less dramatic than the hormonal replacement therapy. Coming to psychological symptoms, isoflavone, especially during perimenopausal period, have shown to improve mood changes and reduce fatigue and irritability. And bone health, isoflavones may help attenuate bone mineral density loss, particularly in lumbar spines, which is more sensitive to their effects. Coming to cardiovascular health, isoflavones may benefit heart health by improving vascular function, by lowering the systolic blood pressure, especially in early menopause. So there are few contraindications like any other molecule. with the history of estrogen-related disease such as breast hyperplasia, breast cancer, uterine cancer, they may exacerbate the conditions. The thyroid function may be altered, especially with iodine deficiency. Patients on anti-estrogen medication. So it has a drug interaction also, especially a common drugs like theophylline, paclitaxel, midazolam, carbamazine, valeric acid, omeprazole, monooxidase inhibitors, and warfarin. So the safety issue and the dosage, coming to that, it is safe, well tolerated, but mild side effects like gastrointestinal, bloating, and stomach upset. But coming to the breast cancer, the epidemiological data and clinical trials have not shown that moderate dietary intake increases breast cancer. And in breast cancer survivor, there's a study says post-diagnosis soya intake was not associated and it lowers the risk of recurrence. But we need to have a personalized approach. Endometrial health, clinical evidence from multiple trials suggest isoflavin supplementation does not negatively affect thickness of uterine lining in postmenopausal women. The dose range from different clinical studies, 50 to 1,000 milligram per day. However, there is no official standardized dose. It has an adverse effect, as I already told. There is a discomfort, nausea, abdominal pain, and diarrhea. Allergic reactions, skin itching, redness, rashes may occur when there is an allergic to soy products. So coming to the evidence, we all practice evidence-based practice. So So there is a randomized clinical trial done with the 84 postmenopausal women. When they consumed isoflavin, especially diadesan, for 12 weeks, hot flush was reduced by 92% and body weight was decreased by 3.6 kg. Another study, this is also a recent one, they screened 12 articles and they found the soya isoflavins were effective for treating menopausal symptoms, and it has a significant effect on other psychosocial, palpitation, depression, and headache also. Another study stating that isoflavin can be an alternative therapy. It does not show estrogenic effect on FST and estradiol, reinforcing that the soya intake associated with reduction in the risk of estrogenic related cancer. They have done a study on risk of breast cancer. It's a systematic study, and the benefit of soya and that is inversely, when the soybean intake was inversely correlated with the risk of type 2 diabetes, and soya isoflavin ameliorated osteoporosis and heart flushes. This is 2023 study. Another study says it significantly reduced serum total and LDL cholesterol, but did not change HDL cholesterol and triglyceride. And this is appreciably seen in when there is a large hypercholesterolemia women. And another study, they concluded isoflavin increases bone mineral density at L2, L4, and at the dose of 59.6 milligram of gencitin with 15.6 milligram diadesin, and reduces bone resorption in early postmenopausal women. And when we look at the guidelines, the international guidelines says research on isoflavin for menopause is ongoing. And while they may help with symptoms like hot flushes and depression, their long-term effects and optimal usage are still being investigated. The NAM says it is currently a mixed evidence for soya food, soya extracts, and soya metabolite equal from widely diverse studies with some significant limitations. Menopause says a very little human data are available, and it's important to read the labels to determine isoflavin content to warn them, the patient, that in India there are no regulations to ensure the content and quality of such products. So it comes under grade C. So what is the limitation? The effectiveness can vary significantly among individuals due to several factors. I told you the absorption depends upon the metabolite equal protection. When to convert it into an active metabolite diadesin. When that equal product is very less, the response will be less. And there is a contradicting evidence. Over 2 decades, the research have failed mixed results, with some studies showing little or no significance when compared to placebo. This is maybe due to the inconsistent research protocols involving different dosage, sources, either food or supplements, and the study duration. Another limiting factor is the different effects. And a lot of studies shows improvement in heart flushes, bone health, and there is no conclusive effect on urogenital symptoms like vaginal dryness or cognitive function. And there is a variation in supplements on whole food, with high soya consumption may come from other components in soya, such as fiber and protein, rather than isoflavone. These are all the limitations of isoflavone. So there is a need for more research because of conclusive results. It is not effective for all symptoms. Though research is extensive, study results are mixed, showing potential benefits of some symptoms while being less effective than traditional hormone therapy. So the future studies should focus on larger sample sizes, standardized intervention protocols, the inclusion of diverse population to provide more robust evidence. In addition, investigating the potential adverse effect is needed to ensure patient safety. To conclude, there is always a progress in science, resulting in new techniques, new discoveries, new ideas. For menopause symptoms, we have widened our drugs. To rock menopause, isoflavone therapy is available when MHT is contraindicated, only after informed choice and a personalized approach. Thank you for patient listening. Women's health is the nation's health.
Thank you, ma'am. Thank you, ma'am, for such a comprehensive talk, wrapped up well in time. And now I would invite Varsha ma'am to give her expert comments on the talk.
Yeah, first of all, I'll congratulate the organizers for starting on time. We are absolutely punctual, and I hope we end the day in the same way. Dr. Hepzibah's talk was absolutely concise and to the point. She has given both sides of the coin, and it's nice to know that isoflavones may work in reducing the breast cancer risk also. Somewhere she has given systematic data about it. And there are so many people, many times they don't like to take hormones, so we have an option for those. Personally, I like isoflavones sometimes, and it was nice to know it helps in osteoporosis also, which is very encouraging. So I think it was a good talk.
Okay, now next slide. So our next topic is holistic health and menopause. And I would like to invite Dr. Darshana Thakkar for this. And ma'am and her CV says it all, that she's a compassionate clinician, skillful surgeon, and emotional health consultant, and a creative human being, aspiring writer, and a mature photographer. And she's also a life coach. So who else can give a better talk in such a holistic topic? So please welcome ma'am, and please go ahead with your talk. Hello?
Yes, ma'am.
Dr. Darshana, ma'am?
Madam is there actually.
Yeah, she's there.
The internet is.
Did she lose touch?
I guess if somebody, am I audible?
Yes, ma'am.
Yeah. So I guess if somebody is calling from the team, I'm here.
Yeah, okay.
So thank you so much for this opportunity to talk at ICOG for my views on holistic healthcare at menopause. It's so heartening to see that so many people Currently, we have 143 on Zoom room to learn more about the midlife management. And when it comes from our own official body, nothing like it. And why am I saying this? Because all of us know that in the era of social media platform and the digital platform, there are a lot of people talking about this subject, and very few is being talked by practitioners and qualified doctors. So I wish and visualize that all these wonderful people who have been doing this course, they go out and shout out loud onto the social media with the learning to educate the society at large. So coming to my presentation and talking about the holistic approach, uh, in simple format, it is something that conceptualizes the involvement of patients' physical, psychological, emotional, and social needs while planning therapy. And it is multidisciplinary approach. So holistic approach does not substitute or replace the conventional gynecological management of menopause or midlife. It is complementary and adjuvant to add on what all we are doing already. So in menopause, if we see a holistic care, it has to be patient centric care. And if we take at least in Indian scenario, women between 40 to 60, they have been in any stage of menopause, pre, peri, or early or later. And at every stage, she goes through a changing dynamics in her own life and in the family. And of course, with the globalization, global thinking, and global exposure via media, she also gets to know what's happening around the world on this issue or this subject. If we talk of Indian context, I'm sure most of you will agree that in our OPD, what we see is she has many unaddressed issues. अगर सिंपली बोला जाए तो सर्व का ध्यान रखने वाली वो महिला स्व के ऊपर ध्यान देना सीखी नहीं है. She'll do everything for everybody. But when it comes to self acceptance, self love, self care, she's been pushed down to the list. And she has her own coping mechanism based on her upbringing, her areas of life, and her own thinking pattern or belief system. Every woman in midlife also has her own set of vulnerability and triggers. Most of the time, the menopausal education comes from the peer group, and they keep talking to each other, whatever they know, scientific or non scientific. And every woman, while gracefully aging through this natural transition called menopause, wants to be happy and healthy. So, though it is a transition, we can also say that menopause is an eco-sensitive disease. What does it mean? It means that her health and happiness is being affected by various factors surrounding her in family, in society, in cultural context, and that is how it becomes eco-sensitive. Holistic approach also includes awareness, education, and management of health education and making her aware of non-communicable disease that may add to the risk factor, because as we know that many of these women are already having comorbid conditions like diabetes, blood pressure, and how can we help them arrest the disease, remission, reversal, anything. All of us gynecologists are practicing based on the fundamental thing of hormones, and HPOA axis is our axis of understanding and practicing and earning. So if we take this science of emotion to midlife, she needs also this oxytocin more, which is a bonding hormone. And this is how the oxytocin, which we talk, is beyond the labor room. Serotonin is being talked by fitness experts, gym trainers, and many more. How can we think about it in holistic approach? So let me tell you that holistic approach management is also something wherein the pharmaceutical management and non-pharmaceutical management is been put to one basket. And when she feels happy in intimate relationship, in family relationship, she feels comfortable, peaceful, and tranquil in her social environment. These happy hormones keeps oozing out of her gut, brain, and heart. We are talking on the last date of Breast Cancer Awareness Month. Let me say here that the long time stress is also known to cause trigger for carcinoma. Ina Siegel, an Austrian author, talks about that the left and the right breast cancer can have the root cause one of as different set of emotions. I know that the allocated time will not permit me talk more about any of this slide, but I'm trying my best to put touch and go of how the framework for holistic care in menopause can be. So when I started this journey out of my 3 decade of practice, and in last 2 decades when I've been parallelly working as gynecologist and emotional health consultant, the holistic approach is very, very essential, I would say, and it gives miraculous results. What all we need is simply readjust and refocus. So, what is it to be readjusted or refocused? For that, the woman needs to be aware, the healthcare provider need to be aware. Woman has a basic tendency to hold on to a lot of emotions. She sometimes forget to set the healthy boundaries. She gets a way out of her routine and do a lot of thing. She's also facing generation gap these days, and all in all, puts her to stress of some kind which is not visible. And when she goes to the yoga class or when she meditates, a lot more comes to her thinking process and thoughts that puts her to the past. And sometimes she feels that I have not lived my life for myself as much as I could have. So when it comes to holistic approach, beyond our gynecological books or hormonal management, these are some of the books which I would recommend for every practitioner to go through. This book talks about physiology, psychology, philosophy, and spirituality. And that can be brought to the basket of our service of holistic approach to menopause. The moment we put this word on the internet as search engine, and we will find lakhs of pages which talks of various things for alternative therapies. How can we as certified practitioners and hardcore allopathy doctor expand our horizon to bring in all this? And for that, is it possible that a practicing gynecologist with a busy OPD can do justice to every midlife woman coming to OPD? I think it's little difficult. So the easier way is to expand the team. And beyond the pharmaceutical industry, if we see that the body, mind, and energy healing market put together runs in billion-dollar industry. How can we get the best out of it for our own client? I here give an example that holistic approach to menopause management is something which is very, very customized and personalized for every woman. The way we have our choices of medicine simply for anti-diabetic or antihypertensive, or for us, the hormone therapy that we choose differently based on her symptom and her issues. Similarly, the holistic approach is also wellness beyond pills and needs to be customized. So pills can suppress a lot of symptoms, but holistic approach can actually make her feel healed, whole, and complete as human being. And as we all know, World Health Organization tells us that the physical health is depending on the emotional and mental health. 85% of the adulthood diseases are caused by psychosomatic reasons that we know. So many of the comorbid conditions, even during midlife and menopause, needs to be checked for the root cause. And every woman is having different trait in managing her emotions. Whether she is suppressing or expressing decides her wellness in a big way. So, along with the history that we are taking, we also need to peep into her world of emotion, how she's feeling. We usually talk, ask, and guide about what she's eating. Similarly, we also need to ask and guide what she's thinking, how she's feeling, and how can it create an impact on her overall health to sail through this magical phase of her life called menopause. In nutshell, the midlife healthcare with holistic approach is under this heading called biopsychosocial model because it is also socio-culturally designed program for any of the menopausal women. If she is having any chronic disease like diabetes or hypertension or thyroid, that care is different. And many of the women in India, they also need to deal with compassion fatigue and her burnt out. So finally, what happens? There is no single specialty that owns the menopause. It is a multidisciplinary approach, and the wellness comes from various different sources. But those sources need to be integrated. बिकॉज अगर वो योगा वाले के पास जाएंगे तो बोले योगा में ये कर लो तो दवाई नहीं लेनी पड़ेगी, मसाज कराने गए तो वो बोलेगी कि मेमोग्राफी नहीं करनी पड़ेगी. इट्स नॉट दैट. The whole point of learning holistic menopause care is integration more than the listing of services. So, who all can be the part of your team when you want to set up a good holistic center for menopause care? Of course, us gynecologists as the strong pillar, aided by endocrinologists, fitness experts, orthopedic surgeons, emotional health consultant, public health specialist, and life coach. When all of them come together, we also need a framework that is holistic care delivered in holistic manner. How is that possible? Because as a gynecologist, we'll be listening to the woman, prescribing hormone therapy if required. We'll refer them to a physiotherapist or a yoga therapist. Then comes stress management, so we need a counselor or a psychologist. Then comes the therapeutic patient education, nutraceuticals, and of course, social and community support. For her, going to a spa for 1 hour and relaxing may be much more beneficial than any kind of a tranquilizer tablet to be taken. So let's move beyond the world of pharmacology and design something which can deliver the complete care in holistic package. Is patient-centered care, wherein the patient is well informed and the decision making for any kind of therapy is a shared decision. Patient is empowered rather than endorsing her victimized midlife. As the goal goes, it has to minimize the discomfort of this transition, and she remained in an eco-sensitive environment with higher level of emotional resilience so that she does not feel uncomfortable. I wish the way ICOG conducts such kind of certification program and such kind of online forums, we someday come up with something that goes online for the general public of India to understand what exactly does it mean. I wanted to talk a lot, but as I know that we go time by time, and this was my humble effort to connect, touch and go to the thing before the clock set for me rings the bell that time is up. I end here. And if this seems to be very incomplete and very quick, we can always connect on my personal mail or uh, phone number. Thank you so
Th-
much for this opportunity.
Thank you so much, ma'am. It was a beautiful, holistic talk. Loved listening to you. And people are asking for the name of the book, so please kindly do share in the
I'll put
chat
it in the
box.
chat box. I'll
Yes,
put it in
and
the
I
chat
would
box. Sure.
invite Suman ma'am, Suman Sinha ma'am, I think she's there uh, to comment on the talk.
Sure.
Suman ma'am is there. Otherwise, Pragya ma'am, please kindly give your comments.
There, can you hear me?
Yes, we
Hello,
can hear you, madam.
Pragya is speaking.
Yes, Suman ma'am, would you like to
Yeah,
say something?
yeah. If you can hear me,
Yeah,
Yes, we can hear you.
yeah.
yeah.
So it was really very nicely. It was very nicely. Well curated topic and well curated talk. She has,
Thank you so much.
I mean, she has covered from the beginning till the end, and we are really stuck to the screen that what next, what next, what next. So it was lovely hearing you, madam, and hope
Thank
to
you.
learn more from you. But since this ICOG platform does not give more time to us, so
Perfectly
sometime
fine.
we
I
are going to
appreciate.
listen to you again. Thank you so
All
much.
thanks to Arshana Dwivedi for the invitation and pulling me here, and Aditi for following it up very, very diligently.
Thank you, Darshnaben, for such an excellent talk. I think I'll share the number in the group or the chat box so
Yeah,
that
yeah,
you'll
you
be
can
in touch
share
with
the
her.
number. So
She's a
you
master
can,
person when you are
in our
need
personal things
happiness.
also, we can ask her
Yeah. Okay.
regarding the meditation and all.
Thank you.
Yeah.
So we have our next talk on menopause and obesity. Gauri, could you please share the...
Yeah, I think no need to share the CV. I've already been
Welcome, ma'am.
introduced.
Yes, ma'am.
Yeah, so I'm just trying to share my screen and show you. Can you please see if you're able to see my screen?
Yes, ma'am. Yes, ma'am. And welcome, Parag sir. Parag sir has joined. Welcome, sir.
I'm traveling,
Welcome, Parag.
so I'm just listening quietly with my audio and video off. Let's get going. Hi, sir.
Yeah. So, good evening, everybody. And at the outset, let me thank Dr. Parag and the organizers for giving me this opportunity to speak to you. And listening to Dr. Darshana was a wonderful experience. And I really think I'm going on to the holistic health part by talking about menopause and weight gain. Because today, one of the commonest problems that patients come with us and their complaints is weight gain. So, weight gain, as we know, is a major health concern for women at midlife. And what happens is that the estrogen level falls, and that favors central fat accumulation coupled with loss of muscle mass and bone. This weight gain starts during the perimenopause, and it is almost 1.5 kgs per year and results in an average weight gain of 10 kgs by the time menopause is reached. And we all know that weight excess will lead to increased cardiovascular risk, diabetes, and cancer. And certain strategies for weight reduction, we can definitely tell our patients, which include diet and regular exercise. So, why does this whole weight gain occur? Now, metabolic rate slows as the lean muscle mass reduces. And what happens is, as the lean muscle mass reduces, the visceral fat is increasing. And this is increasing from 5 to 8% of the total body weight to as much as 10 to 15%. And this visceral fat is very, very dangerous. And that is what is resulting in insulin resistance. Now, there's a very beautiful article written by Mr. Dr. Simpson, and Dr. Simpson is from the University of Sydney in Australia. And he talks very beautifully about how the menopause transition, if you see my algorithm on the right hand side, this impaired and intermittent ovulation and menopause transition is leading to intermittent low E2 levels and intermittent high FSH levels. This is what is causing now enhanced muscle breakdown, and so the body requires more protein. And then there is a hormonal signal which comes from the muscle and from the liver, and there is what is called an enhanced protein appetite. Now, if the woman takes that enhanced protein appetite and increases her dietary protein, then her energy intake is going to be unchanged and she's not going to put on weight. But in case the enhanced protein appetite is not met by increased dietary protein, what is going to happen is that she's going to take more carbohydrates and more fats, tend to eat more, and she's going to have a higher energy intake, and therefore the weight is going to go up. And this whole thing has been described by him as a protein leverage effect. This whole protein effect is very important. So, what happens is the hormonal signal from the muscle is from the fibroblast growth factor 21, which is a peptide. It is synthesized in the liver and the muscle, and it is a hormonal signal of protein deficiency. And so, protein leverage is the term which is used when protein becomes diluted in the food supply by fats and carbohydrates. What women do is more energy is necessarily therefore ingested in attaining the target intake of protein that signals satiety. As the protein intake increases, if they increase the protein intake, then the energy intake is restricted. But if they fail to change the composition of the diet, it's going to result in increased body weight. So, rational modification of the diet is the key to ameliorate or prevent weight gain at menopause. Now, when we look at carbohydrates, just a few tips on diet. We have complex carbohydrates, simple carbohydrates, and refined carbohydrates. And we all know that there's the good carbs and the bad carbs. And the glycemic index is very important. Carbohydrates which have a low glycemic index are slowly digested, absorbed, and metabolized. And therefore, they cause a lower and a slower rise in blood glucose and therefore insulin levels. So visceral fat is less and they have insulin resistance is managed. So good carbohydrates are whole wheat, oats, dahlia, whole grain pulses, sprouts, fruits like apple and guava, unpolished rice. But when we look at refined carbohydrates, which have little nutritional values, are all the very, very nice things that we can see here on the right-hand side. When it is biscuits, white bread, you can see a croissant there, polished rice, aerated drinks, junk food, bakery items, and vegetables like potatoes and arbi. So if a little modification in the diet will help the woman to maintain the weight. They must avoid sugar like crystalline sugar, sugarcane juice, carbonated beverages, fruit juices, and sugar syrups because these are an absolute no-no. What about fats? There are healthy fats, and fats are a rich source of energy. They must be consumed because they're a rich source of fat soluble vitamins. And if a diet which has no fat at all will have a vitamin deficiency. But excess increases the risk of obesity, heart disease, stroke, and cancer. So we have the concept of good fats, unsaturated fats, and trans fats like bakery products, samosas, and jalebis, and gulab jamun, which are trans fats and are not healthy at all. So women should be encouraged to have, if they have a little butter, a little ghee, a little coconut oil, egg yolk, it's absolutely fine. Now, we also have good fats in avocado or olive oil, groundnut oil, sesame seeds, which won't raise the cholesterol. And we have things like polyunsaturated fatty acids, where sunflower oil, groundnut oil, chana, rajma, walnuts, etc. Antioxidants should be part of the diet. Tomatoes, lycopene, citrus fruits, probiotics like milk, cheese, and yogurt. Strawberries have anti-inflammatory properties, and even a little bit of chocolate actually is a stress buster, lowers blood pressure, and improves insulin resistance. So you can see how important the diet is and what each constituent of the diet is very, very important. For a good source of calcium, they should have milk and milk products, fish, green leafy vegetables, nuts, and dried beans. But we know that if they try to get the entire amount of calcium through milk and milk products, the number of the calories will go very high. So they have to be limited in doing that. What the biggest question I get in my practice, but we are vegetarian, what can we have as protein? So I like this slide because it tells in very simple words. If you have dal, chana, rajma, lobia, you can see how high soybean is, 28 grams per cup. Tofu is 10 grams per cup. But these are not really part of our diet. But even simple things like dal and chana and rajma and lobia are good. Peanuts are good, of course, paneer, yogurt, milk, rajgira is so much part of our diet. Newer things like quinoa, chia seeds, flax seeds, pumpkin seeds, these are all available now, and we need to include them in the diet. And of course, almonds. Phytoestrogens are important, and things like soybeans, tofu, and soya milk and flax seeds, chickpeas, beans, they are all very good for avoiding hot flushes and for menopausal symptoms. They have estrogen-like properties and can be consumed. And of course, for women who have hot flashes, they should avoid spicy food, caffeine, and alcohol. Identify triggers and drink enough water. So I think the bottom line of everything is right from the age of 40, women should eat less and eat better. Eat a variety of foods. Make sure that there is some calcium like dairy products, broccoli, and legume in the diet. Have a good source of iron like green leafy vegetables, fish, chicken, egg, and nuts. Good fiber in terms of whole grain bread, cereals, fresh fruit, and vegetables. Drink plenty of water. Be careful and reduce foods rich in fat. Be very careful about sugar and salt in moderation, and limit the alcohol intake to 3 to 5 drinks, of course, or social drinking whenever required. So I always tell my patients that don't go to a buffet and start from the beginning and just fill the plate with everything that you see. Go and think first, what are you going to eat and how you're going to balance your meal, and then go back again and fill the plate. Then, of course, move more. Very important. 150 minutes per week will go a long of exercise. A week will go a long way in maintaining weight, or 10,000 steps per day. The exercise program again should be tailored to resistance exercises, strength exercises, and 1 or 2 sessions of gym where there are squats and bicep curls and other muscle exercises will definitely improve muscle strength and also improve bone strength. So I think that what the British Menopause Society says is keep a logbook, and you can tell your patients keep a food and activity diary. Avoid large portion sizes. Avoid unstructured meal times. Try to have regular meals. Unconscious snacking while watching TV and things should be avoided. Limit alcohol intake. For those who have long periods of being sedentary, try to block it and get up and walk. Get up and walk. Take the steps. Don't take the lift. Or during your lunch break, have lunch and then go for a walk. Again, very quick eating is not a good thing because there is no time for the satiety center to be activated. You will just keep eating more and more. And unbalanced meals and unbalanced food groups is not a good idea. So, we of course can't achieve a change in one day or 1 week or 1 month, but slow and steady, little by little, we can guide our patients and they can eat better and eat more healthy. So I'd like to say that our key other strategies are medications. Of course, metformin is a useful drug for overweight women who have diabetes or the risk of diabetes. Today, Ozempic and tirzepatide are also available. Even bariatric surgery is recommended for morbid obesity with medical problems. But I think that if we initiate the discussion early in menopause, in the perimenopause group, maybe we will be able to curtail this problem of excessive weight gain when our patients reach the menopause. Thank you very much for a patient hearing.
Thank you, ma'am. I would now request Pragya Mishra, ma'am, for her expert opinion on this talk. Ma'am, you are muted.
Pragya is on mute. Please, host, please allow Pragya to unmute. Who's the host?
Ma'am,
Yes.
yeah, yeah. I was there. I was muted from that end. Hello?
Yeah,
Ma'am,
Pragya, we can hear you very well.
Yeah. No, I was saying that I was muted from the other end, so I couldn't unmute myself. It was a very, well, first of all, I would say thank you to ICOG for letting me chair such a prestigious session, that too where a secretary ICOG, such a dynamic, hardworking person like Dr. Sarita Bhalerao is a speaker. And thank you so much for letting me chair this session. Your talk on weight gain and menopause was so clear and so informative. I mean, you started off with, why this happens and, how the pattern of weight gain, how women tend to weight gain from the time they are in their 40s. So one really has to choose, I mean, eat less and choose what they eat. And not only that, the fact that, you have laid so much stress and what is the best food to eat, like you threw light on about the kind of carbohydrates, simple, complex, and which are the good ones. So and also laid stress on the proteins. I think it was a highly informative talk, Dr. Sarita, and and 1/3 of the women, their life is spent in menopause. I mean, after menopause. So I think I'm sure that it must have been quite beneficial for all the delegates who have joined in today. It was a wonderful talk with very good take home messages also.
Thank
And
you, Dr.
especially,
Pragya.
and about the brisk walking and all that, you also, I mean, you did not leave anything. So right from food and the kind of food and looking after the physical work and everything that one has to do, it was fantastic, Dr. Sarita.
Yeah, I'd like to just add one thing. The list of proteins which you showed, na, I found it very interesting. But because so many times we forget, adding Rajgira and all that, you can make a list and put it there in your consulting room. And targeting the women at the perimenopause is a very good suggestion idea. And protein leverage, of course, Pragnya also just mentioned. So eat less, eat better, and move more. That's the motto. Thank you. Very nice presentation.
Yeah.
Thank you, ma'am. Now for the last talk of this session, which is on the omnipresent genital urinary syndrome of menopause. And I would invite Dr. Neeta Mishra. She has been the Ahmedabad member of Ahmedabad Menopause Society, has been the Digital Education Committee chairperson of IMS from 2025 to 27, President Ahmedabad Menopause Society, Organizing Secretary of Eurogynec Conference. So please, ma'am, welcome and please go ahead with your talk. The tech team will have to change the slides, ma'am.
No, madam has started.
Yeah.
With her.
Thank you very much and good evening, everybody. Thank you very much for having me here. The office bearers of the ICOG and the Foxy and all the like Parag, Sunita, Sarita and Suvarna, all the coordinators and the conveners, Dr. Archana, thank you very much for inviting me here. The topic is GSM, that is genitourinary syndrome of menopause. Each and every woman may be passing through these symptoms of the GSM. So the Malala Yousafzai, she said that we cannot succeed when half of us are held back. 25% of the woman's life, she may be passing in the very poor health in comparison to men. So one of the most consistent predictor of the impaired sexual health in women is the vaginal symptoms. Unlike the other symptoms of the menopause, the GSM symptoms always worsens as the time passes. Being a healthcare professional, it is our duty to diagnose it and to manage it as early as possible. The GSM term is given by the American Menopause Society in 2014. So it's not a very old term. It includes the LUTS, that is the lower urinary tract symptoms, and the vulvovaginal atrophy. Previously, it was known as the atrophic vaginitis, and it was not covering the full spectrum of the symptoms, and that doesn't show that it is all because of the low estrogen. So the new name has been given. Physiologically, if you see, the vulva, vagina, and the lower urinary tract and the pelvic floor, they have the same embryological origin. So accordingly, they all share the similar hormone response. GSM affects almost 70% of the postmenopausal women. There are three different types of estrogen in women, like ethylene estradiol, estrone, and the estriol. Ethylene estradiol is the most potent estrogen, and it is mostly you will find it working in the puberty and the childbearing age. As the woman enters into perimenopausal age, it becomes weak, and the weak estrogen, that is the estrone, that becomes active, and that will lead to the deficiency of the estrogen or the low estrogen in perimenopausal age. There are two different types of estrogen receptors, type A and type B. Type B are more prevalent in perimenopausal age, and they are the weak estrogen receptors. So Viva study showed that the 50% of the Canadian women say that they have never seen that the treatment for the GSM is available, and they said that the 59% of women said that doctors have never, raised the question of the postmenopausal genital. That this is all happens with us also. In our busy OPD, we never discuss about the genital health. The woman may be having some restrictions. She may not be open up to the doctors, and she's not sharing her problems. So we have to create the environment so women can share her problems. The Associated Closer study said that 50% of the women find the GSM is very distressing. The main complaint of the GSM is the vaginal dryness. You will find it in 93% of the women. If the patient comes to your OPD, and if you examine the patient on pearl valve examination, and if you find that the pearl valve examination is absolutely normal, that doesn't mean that she is not suffering with the severe symptoms. A normal examination doesn't exclude the diagnosis of the GSM. So diagnosis is very important. And to talk with the woman is very important. We have to find out some time for them. For that, I think we need the darshana for that. And we need some time from our busy OPD for the women. Investigation as such, if women enter into the OPD, you can immediately prescribe the treatment. Specific investigation are not needed. Cervical screening should always be done. If patient doesn't allow, nowadays people are not doing, all the gynecologists, younger generation, they do the TVS, but the PS exam, pulse examination is very necessary. If it is very painful, you can use the either the estrogen, lidocaine gel or the ointment, or you can prescribe the local estrogen therapy, little bit on a safer side. And you can ask her to come for the follow-up after 1.5 months, and she will be definitely allow you to do the PS examination. If the patient is having either the urinary problems and the recurrent UTI or the OAB, routine micro is very important. Having abnormal vaginal bleeding, that investigation are necessary. Vaginal discharge, vaginal swab for finding out the sexually transmitted infection, and systemic disease investigation may be required if necessity. Nice menopausal guidelines say that treatments are very safe and they are very cost effective. So what is the impact of the GSM? Estrogen and testosterone receptors are both are present in, I already discussed about that. And GSM symptoms may affect the woman, those who are breastfeeding and those who are only on the progesterone, only contraceptive pill. So they may cause the low estrogen, they may have the symptoms of GSM. So they should be taken care. These are the symptoms and signs. I'll not go into detail. All the perimenopausal women should be asked about the GSM, whosoever enter in your OPD in the perimenopausal age. If the right question is asked in the right clinical setting, she will definitely be open up. If patient is on the radiotherapy or the chemotherapy, or she has undergone the surgery, they have high risk of GSM. Those who are having inflammatory bowel disease, diabetes, multiple sclerosis and stress, they are associated with the vaginal dryness. Drug-induced GSM can be drug-induced in perimenopausal age, like the tamoxifen, antihistamine, decongestant, and antidepressant. That should be kept in mind. So how the GSM affects the woman with the low, learning disabilities or the dementia. So the woman may present with some behavioral changes because of the vulvovaginal discomfort. And there is no research how the menopause affects the woman with a low IQ, but it is said that the GSM sets in early in the Down syndrome patients. Female genital mutilation. Nowadays, everybody wants to have some cosmetic gynecology and aesthetic changes in her private parts. So if she has undergone the female genital mutilation, that patient, the GSM symptoms exacerbates in those patients, and pain, irritation, and sexual dysfunction. But she may not come for the help. Maybe the barrier, FGM may be the barrier for seeking the help. We should not forget the trans individuals. They also they also have the GSM symptoms. So they should also be treated if they need the help. And they are also having some barriers for seeking the help. Histologically, if you see what are the changes happens into the urogenital tract, there will be atrophy of the urethra, increase in the urethral epithelial transitional cells, and decrease in the intermediate and superficial squamous cells. The smooth muscle of all the urogenital tract will be atrophied, and there will be reduced collagen and elastin, and there will be loss of the vaginal rugae. And on this basis only, the aesthetic gynecology is working, that you need the collagen and elastin in your organs. The vaginal epithelium becomes pale, friable, and can tear easily. They bleed, and particularly during the intercourse. Now comes the main topic, the management of the GSM. Different modalities available for the GSM treatment. First and foremost is the lifestyle modification. The smoking should be stopped. If the husband is smoking, the woman can have a dryness of the vagina. If she is smoking, she will definitely have a dryness of vagina. Vaginal estrogen is always preferable. Before that, one can use the non-hormonal vaginal moisturizers and the lubricants. Other local hormone preparation can be used, like the SERM or the DHEA, and the systemic hormone replacement therapy, HRT or the MHT. What is the principle of GSM management is to restore the urogenital physiology and to alleviate the symptoms. Lifestyle modification, every woman should continue with their sexual activity, because there is a positive link between the maintenance of the vaginal elasticity and the lubricative response to the sexual arousal with the sexual activity has been demonstrated. If woman continues with the sexual activity, the vagina will be elastic and there will be some vaginal secretion, so the lubrication will always be there. Non-hormonal therapy, the vaginal moisturizer and the lubricants are recommended to women either alone or along with the systemic or the vaginal MHT. Vaginal moisturizers can be used on a regular basis. Vaginal lubricants are used when there is a penetrative activity, like the either the intercourse or the some pelvic examination has to be done. But they should be the vaginal environment friendly and free of all the potential irritants like the glycerol and the glycerine.
vaginal moisturizer and the lubricants, they do not restore the normal vaginal pH. So you are giving the symptomatic treatment, but not the covering the reason for the GSM. So they are on a temporary basis. Lubricants, they are preferred in those patients those who they don't want to go for the non-hormonal treatment. I mean, they prefer to have a non-hormonal treatment, and especially in the mild symptoms. These vaginal lubricants can be used with either the estrogen or the DHEA, but at a different time. Other the absorption of both the things will not work together. Oil-based lubricants can have a negative impact on the condom integrity. The patient is having in a perimenopausal, if she is 43 or 44, she can have a chance of pregnancy. So in that case, if she's using condom, and integrity can be affected. Commercially available lubricants are the water-based, silicone-based, mineral or plant oil-based products. They are applied to the vulva or vagina or the partner's penis if required prior to the sex. Moisturizers are the bioadhesive attached to the mucin and epithelial cells of the vaginal wall. They retain the water, so the moisture will be there. They balance the vaginal pH and they mimic the vaginal secretion. So they are as good as the vaginal secretions. For the breast cancer survivors, lidocaine compresses are the best treatment. Use of the liquid lidocaine compresses to the vulvar vestibule before the sexual penetration. It gives a promising results in the breast cancer survivors, and almost 90% of the patients reported comfortable intercourse. So this all history is all because of the lack of the estrogen. I mean, the one word we can say that the hormone replacement therapy or the MHT is the ideal treatment for them. It's a gold standard. Either you can use the estrogen, you can use it systemically, orally, but orally doesn't have that much good response in comparison to the genital, in comparison to the vaginal preparations. May improve the vaginal and urinary symptoms. It will improve the OAB, but not the SUI. Transdermal, you can use spray, patch, or gel. Everything is not available in India. Subcutaneously implant can be done, and vaginal has the best outcome in patients with the GSM. There are two types of estrogen used, estradiol and the estriol. Vegisert, 7 milligrams suppositories, it is available in India, and it gives best results in genitourinary syndrome of menopause. We are using every day in OPD the Primarine and Evalon cream. Conjugated estrogen is 0.6 to 5 milligram, and Evalon has the estriol. If you count how much vaginal estrogen is absorbed, the dose of vaginal estrogen is very low. If the 210 microgram estradiol cream is used twice a week for 1 year, the total dose is roughly equivalent to 1 milligram of estradiol tablet, considering 100% is absorbed, which is very unlikely. So vaginal absorption of the estrogen is very low, and so relatively it is very safe in comparison to the oral MHT. So if the treatment is started earlier and it restores the anatomy and physiology and prevents the progression to the disease, I should not say disease, and more severe changes such as the labial resorption or the clitoral atrophy. If the symptoms do not improve with the vaginal estrogen, you can increase the dose. You can use two tubes at a different time. I mean, combining two local treatments. You can change the preparation, consider the DHEA, or you can shift to the systemic MHT. These are the doses of the systemic MHT. These are the MHT regimens. Body identical hormone therapy is the safest, but trial should be considered for the woman with the prolapse. There are some other benefits also, like the prevention of osteoporosis, CVS disease, and dementia. Vaginal long-term estrogen therapy, you don't need progesterone for that because it's a very low dosage. And symptoms return if you stop the treatment. There is no need to stop the treatment. You can continue vaginal estrogen therapy for a longer period of time, but that patient should always be followed up. We are a little bit lacking in somewhere in the follow-up, but if you are on the MHT or the local or systemic, the follow-up is very important, or pap smear and all the other investigation. A low-dose DHEA, a vaginal insert used daily with an applicator, recently approved in Canada for the treatment of moderate to severe dyspareunia in menopausal women, but it is not available in India. Women should be treated initially for 3 months and then can be reviewed. But DHA we are not using in India, so I'll not go into the detail. DHA does not carry a contraindication for the history of the breast cancer. It is the advantageous for us. Testosterone can be given for the those who are having the low libido. So 10 to 25% of the women with the systemic MHT will have a persistent urogenital symptoms. In that case, you can 100% add the vaginal hormones to systemic MHT, and that gives the better results. One more thing is available in the market is the SERM, that is a selective estrogen receptor modulator, that is osmipen. There is no negative effects on the endometrium, and it is not associated with the risk of the thromboembolism or the breast cancer. So this has an advantage on the estrogen therapy. And the nutraceutical, the EFSIBA has already said about the phytoestrogen, but there are no sufficient data has been available for this, whether it is effective or not, but we can 100% give the phytoestrogens. Alternative and complementary therapies like the vitamin D, vaginal vitamin E, and the probiotics, they also give the good results for the GSM. Now they come to the point, like I am also doing the aesthetic gynecological practice, and Dr. Ragini will cover everything. These are the devices which are available in the market, the different devices and the different way they are working. But however, 2 randomized controlled trials have been demonstrated that the laser is no better than a placebo. So it is not giving good result, but we are getting the result. That is, this is just a statement. So hence the laser treatment is not available in NHS. This is our own article. We have already done this study of the 250 patients. And this is a study of the 200 patients when we had compared the 110 women with the 90 women with the active probe and the sham probe. Sham probe means we have just used the inactive probe, and whether to find out the comparison between the two probes. And we found that it is effective for the vulvovaginal rejuvenation and for the 100% for the overactive bladder. This is our poster presentation in Ayuga in 2023. This is review article in the transcutaneous temperature controlled radio frequency. It's a groundbreaking technology, and it is giving good results in the SUI and the overactive bladder. And it's a non-invasive technique. So it is published in the journal. Patients with the gynecological cancers and the GSM. So for the gynecological cancer, we the first and foremost should be safety. For that, vaginal moisturizers and the lubricants, they are the best preference. Local hormonal vaginal preparation can be given because the absorption is a little bit less, but woman should be reviewed every 3 monthly. So advice to the woman, all these irritants should not be used, but they should wash the perineum with emollient or with a soft soap and with the lukewarm water, and they should wear the cotton underwear is preferable to the synthetic fibers. So in summary, if you see the majority of the postmenopausal women experience the symptoms related to GSM. Only a few currently get the treatment. Too many women do not talk about their symptoms, and too many doctors like us or the healthcare profession do not inquire about the symptoms. GSM symptoms do not improve spontaneously. They need the treatment. Treatment is safe, cost effective, and usually works very well. Vaginal estrogens and the DHA can be used safely for a longer period of time. A combination of the different treatments can be given. Woman can receive the systemic and the local estrogen concomitantly if she is taking oral tablets. She can be added the local estrogen if she is not getting relief in the GSM. Woman with the history of the breast cancer can usually be given the vaginal hormonal preparations. Thank you. Thank you very much.
Thank you, ma'am, for the elaborate talk. And I would request Dr. Suman, chairperson of the first session, Dr. Suman or Dr. Pragya, ma'am, please to comment on the session.
Yes. It was Dr. Nita Mishra's talk on this genitourinary syndrome of menopause. I mean, it was again a very, very highly informative and very clear talk, Now, it's this genitourinary syndrome of menopause is such a common problem in menopausal women that, and I would just say like it's one of the unspoken problems because a lot of women in this age group, they suffer from symptoms like, vaginal discharge and urgency, vulval itching. But, I think most of them, not most, but quite, I would say a majority of them, they don't get treated properly. And sometimes, and they are quite hesitant also to speak about it. So Dr. Nita has dealt with, most of the options which are available, like, depending on what is the exact symptom. So starting from gels and lubricants to estrogen. So I just wanted to ask her one thing, like what about, vaginal isoflavons? Because there was a company which had for quite a few years it had come up with this isoflavone gel. So
Yeah.
recently I'm surprised
I
that
think
I don't know.
Juventus has come with the,
I know. I didn't want to take the name. And it
yeah,
was, like, and patients used to literally come and thank me for that Icerine gel. But I
yeah,
don't know why, they just stopped
yeah,
manufacturing it. I mean, what could be
yeah.
the reason? I mean, it was working.
Actually, I think Dr. Yeah, it was a little bit expensive, and I think it was working as a moisturizer rather than the fire isoflavone gel. Because I had a discussion with, because I was also interested in that, and I was prescribing a lot with the patients, and it was giving good result. It was giving very good
No,
result
no,
because you are
no,
not
what
afraid of
I
the
found.
hormonal preparations.
Yeah. No, no,
Yeah.
what I found that women who were presenting with, too much of vaginal discharge in this age group of non-infective cause, it was really helping very well because, and it was just twice a week for about 12 weeks. And not only that, like, I even on when I did colposcopy on these women, because, if they have atrophic vaginitis and all that, it doesn't take up iodine, Lugol's iodine well. And after 3 months of application of this gel, I mean, the total picture used to, the colposcopy picture used to change. Like it used to look so well estrogenized with all, I mean, with all the Lugol's iodine which it used to take up. So I'm really surprised. I don't know whether any other company is manufacturing vaginal estrogens. I mean, because patients were responding very well to it.
Yeah.
So I think
Yeah, it was
apart
giving
from,
very good
of
result.
course, you have mentioned about, 0.625 of conjugated equine estrogen and that Evalon cream and all those things, like which is estriol. Those, of course, they work very well.
Yeah.
But the women, who are inhibited to use hormones, for them, the vaginal isoflavones worked very well.
But it is, that was quite good, but they have stopped it. And women are always afraid of the hormones. Like being a doctor, we are always afraid of the hormones.
Mhm.
If you are prescribing vaginal preparation, even though you have to undergo the follow-up, and being Indians, we are always a little bit, delay in the
The patients
follow-up.
are shy, I think.
Yeah. So that therapy was absolutely good, but up till now, not a single company has come up with the Israel or the pelvic gel and all that.
I think it was expensive also, Nita. It was expensive also. What
Yeah,
I
this is what I said. It was expensive.
Green gel, it
Yeah.
was to be used as a moisturizer actually.
Yeah, exactly. This is
Yeah,
what I say
it
to
was
Dr. Pragya.
little expensive. And then
Yeah.
vaginal use, which our females don't like so much, maybe that was the thing.
And actually, patient's acceptance was really good, but I don't know why the company has stopped it. And doctor's
Patient,
acceptance was also good, but
no, patient acceptance was
yeah,
very good. I mean,
very
they used
good,
to
very
come
good.
and
And we
thank
are
me
also
for
getting the
that.
result. We were also getting
Yeah.
the result. Yeah.
I mean, it was okay, fine, but only 2 tubes were had to be used per week, so I wouldn't say it was that expensive either. But I really don't know the reason, why it was withdrawn. maybe, they may just come up in a few years. That's what.
Yeah, let's see. Hope for the best.
But
Okay,
really, I
okay.
mean, to sum up, I would say that this aspect in menopause is, I feel, quite a neglected sort of area.
Of course.
And I think we really need to look after these women, menopausal women, as gynecologists. It's our duty
Yeah.
not to like sort of shove away their complaints, but really, something to be focused
Yeah,
upon.
everybody
Because
has to spare some time and listen to them carefully.
yeah,
It is
to
very
give them
important.
a better quality of life
Of-
to these women.
Thank you,
And thank
Pragya
you
ma'am.
so much. It was a
Thank you.
wonderful talk.
Thank you.
And
Thank you very much.
yeah.
Thank you,
Thank you,
organizers.
ICOG, once
Thank you,
again.
organizers, for giving us a chance to be the chairperson. Thank you.
Thank you all the
Thank you.
chairpersons and speakers of the first session. And I'm requesting the speakers from the first session to please answer the questions in the chat box. Please look into that. And now we'll start the session 2 on MHT. So I would like to welcome the chairpersons, Dr. Sandhya Khare. She is the co-director, Khare Nursing Home and IVF Center, Devas, recipient of 5 gold medals and prestigious President's Silver Medal. She has various publications to her names, and her interests are in high-risk pregnancy, menopause, and preventive oncology. Welcome, ma'am. Our second chairperson for the session is Dr. Shanti Guna Singh, who is the professor of OG Aruna Medical College. She has been the past president, OG SSI, Chennai Menopause Society and Women Doctors Association, Tamil Nadu, former director and superintendent, Institute of Obs and Gynecology and ISO KGH, and former head of the department at Kilpauk Medical College. Welcome, ma'am. Then I would like to request and welcome our third chairperson for the session, Dr. Geeta Balaskar, who is the professor and unit head at Norsoji Wadia Maternity Hospital and State GS Medical College, Mumbai, honorary consultant, Tata Memorial Hospital, Mumbai, editor emeritus, Jyogi, and editor-in-chief, International Journal of Infertility and Fetal Medicine. And she has many posts to her name and recipients of various awards. Welcome, ma'am. Now, the first talk is on oral MHT, and we have Dr. Jyoti Jaiswal, who is the professor and head of the Department of Obs and Gynae, Pandit JNM Medical College, Raipur. She'll be speaking on it. Ma'am has been the National Treasurer IMS 2024-26, Vice President Chhattisgarh ISAR, Secretary General Raipur ISOPAB, Secretary General SOFC Chhattisgarh Chapter, Treasurer Chhattisgarh IH. She has organized various conferences, published many chapters on Infoxy and IMS publications, has many awards and recognitions to her name. So without wasting any more time, I welcome Dr. Jyoti Jaiswal for her talk. Welcome, ma'am.
Thank you, Aditi. Can I just share my screen?
Yeah, sure.
Is it visible?
Yes, it is visible.
Proposing hormone therapy.
Yes.
Yeah. Is it full screen now, Dr. Aditi?
Yes,
No,
it is.
not
It is. No, it is full screen now.
Yeah. Thank you so much. First of all, I thank the office bearers of the Foxy and ICOG, Dr. Sunita, Subarna Madam, Dr. Parag and Sarita Madam, and my dear friend Archana and Aditi, to you to incorporate me in this prestigious webinar. And I have been given a focused part to talk about that, the only oral part of the MHT. So the requirement of MHT is there because a very large number of the postmenopausal women are with us, and out of them, two-thirds remain symptomatic. So they need treatment, and some need in form of the MHT. So the primary benefit of oral MHT, why we need to discuss separately the oral MHT, because the primary benefit of oral MHT is its effectiveness in providing systematic relief from a range of moderate to severe menopausal symptoms. And not only that, the other benefits towards the whole body is also there. So unlike topical, oral therapy provide full body hormone absorption, making them suitable for widespread symptom relief and benefits like for the bone, for the muscle, but simultaneously it may give some potential risk due to first pass metabolism as well. So there is a need for the personalization of the medication for the oral MHT. So one size do not fits for all. It is we have to individualize for each woman, required a tailored approach. So now first thing, that who can start MHT? So the patient who is within 60 years of age, 10 years, within 10 years of menopause, do not have the high risk for the CVD or VT or breast cancer, and she is symptomatic without any contraindication for MHT, that lady requires MHT and she can start MHT. In some portion of the women who are even more than 60, more than 10 years of the post menopause, in general, we do not prescribe them this, but we can start cautiously with clear indication if the condition is severe and it is affective very much the quality of the life. When to avoid the MST, it should also be known. In general, elderly women more than 60, more than 10-year postmenopausal with high risk of history of stroke, MI, VT, active liver disease, high breast risk, breast cancer risk, etc. These are not the right candidate for the MHT. And there are few FDA approved indications as well for MHT, like moderate to severe BMS. For prevention of osteoporosis, we can give if diagnosed osteoporosis is there, and it will be better if we give them in window of opportunity. The GSM symptom treatment can be given and better relieved by the local therapies, and hypoestrogenism from premature ovarian insufficiency or surgical removal of the ovary are the candidates who are FDA approved indications. So we have the large range of the hormonal products to be given for this, but here we will concise ourselves and will discuss basically the natural estrogens and progestrogens, because the tibolone and the other things has to be dealt with the other speakers. So we have two type of estrogens, natural estrogens and some synthetic estrogens as well, like ethinyl estradiol is basically used in the oral contraceptives, but the near natural estrogen like 17 beta estradiol, estrone, estriol, these are commonly used in the MHT, and even the conjugated equine estrogen can be used. So out of all these estrogen, we try to have 17 beta estradiol because of you can see very well in this picture that the load to the liver, as we said that first pass metabolism effect remain on the liver, so the load to the liver remains minimum with the natural estrogens like 17 beta estradiol. Even CE has some more stress on the liver. So now we should understand that what is the various doses which can be given. So there are various protocols, ultra low dose, standard and high. So conjugated equine estrogen is low dose 0.3 and 0.45 is considered as low, 0.625 considered as standard, and 1.25 as high dose. Similarly, 17 beta estradiol, which is the dose is equally effective with the conjugated equine estrogen. If 1 milligram is taken, then it is considered as low dose, 2 milligram standard, and 4 milligram high. 0.5 becomes the ultra low dose, and it requires either in tapering format or somewhere when the patient is very, very less symptomatic. Coming to the progesterones, again, the natural progesterone, micronized progesterone are structurally identical to the corpus luteum derived progesterone, and they are preferred due to the better tolerability. We can use synthetic progestins as well, but the natural progesterone or the dihydrogesterone, which is like natural progesterone, is better to use. Micronized progesterone also improves for the sleep, and it is comparatively less thrombogenic versus the other synthetic progestrogens. We always think that estrogen is very thrombogenic, estrogen is thrombogenic, but the progesterone are also thrombogenic, especially the synthetic one. So the natural one is better. Use when you decide about the dosing of the MHT, so use lowest effective dose if you are taking systemically, and you can tailor based on the root tolerance response itself. But we always talk more and more about the lowest required dose. Why? Because benefit of HT can be maintained with the lower doses as well, with the increased continuance and compliance and decreased side effect. And when we see the efficacy in prevention of the osteoporosis is similar or not, so it is not compromised. So we can go ahead with the lower HT doses. There are some exceptions for the low dose therapies. where the low dose will not work properly and you need to give the standard dose, like premature ovarian failure, severe osteoporosis, predominance of psychological problems like climactic depression along with the vasomotor symptoms. So those cases require the standard dose. Non-oral therapies will be dealt by the other person. Now we should understand the concept in the prescribing hormone therapy. So we should identify the goal of the treatment problem. What is the basic problem? Whether it is hot flashes, whether it is the vaginal GSM, or whether it is the bone issue. So you identify the goal, rule out contraindications, counsel properly about everything, about the dose, about the time period, about the side effect, and see if two patients are there with same dose, they can have the different kind of the responses. So individualization here again is important. One more thing which is very important, if the patient is symptomatic, it's always best to start early to give them maximum benefit. And in the earlier period only the estrogen fluctuations remain more. So they will have more benefit of the symptoms relief, as well as the more benefit towards the general health, bone health, muscle health, etc. Now, a few more points to consider that when to start. So one is early window of opportunity, what therapy, which regime, how to tackle the side effect if they are there, how long to give, when to stop, what will be the follow-up. These things you have to keep in your mind while you are prescribing, and you counsel all of them to your patient as well. So this one simple chart makes you understand so many things, that there are two type of the menopausal therapy. One where the only estrogen is required, where the uterus is not there, endometrium is not there, except for few conditions like endometriosis. Even the post hysterectomy you can add on the progesterone. Otherwise, no uterus, no need of the progesterone. The second thing is EPT, estrogen progesterone therapy. This can be of two types: the continuous sequential MHT, which is basically like in the perimenopausal period or in early menopausal period, it is better to give. Continuous combined MHT is the same dose, same content of the estrogen as progesterone, started from the start of the cycle to the end, and there is no break for the cycle, no bleeding at the end of the cycle. You will continue the same treatment for the longer time. So coming to the estrogen therapy, where only estrogen continuous therapy is given, the dose, low dose is 0.3 CE, standard 0.625 mg CE. If you take 17 beta estradiol, 1 milligram or 2 milligram, and high dose is 4 milligram. For the continuous sequential EPT, where the women with uterus, she is in peri and early menopause, again you can use the 17 beta estradiol or estradiol valerate 1 milligram or 2 milligram depending on the condition. Like you will need the standard if the patient is having the premature ovarian insufficiency, etc. The oral CE dose will also 0.3 and 0.625. So, and progesterone add-on, you can have either micronized progesterone 100 or 200 microgram, or dydrogesterone 10 milligram for the sequential regime, where the estrogen will be throughout the cycle and progesterone will be in the second part. Now coming to the continuous combined EPT, the 17 beta estradiol and dydrogesterone combination of 1 milligram and 5 milligram continuously for long time, 3 months, 6 months, it can be given. It can also be in place of 17 beta estradiol, CE also can be used, and one can add either micronized progesterone or dydrogesterone. So this is for the postmenopausal women, at least more than 1 year of postmenopause. So proper documentation of postmenopause, then you can start this continuous combined regime. Now coming the question for the follow-up of these patients, that how to follow up and to call. So definitely after 1 month, whether how they are responding, then 3 months, and then annually. Review for efficacy, side effect, and compliance, and regarding the continuing or modifying the HT, because it is not always that whatever dose you have given is the perfect dose. She may need more dose than that, if she is comfortable, even you can decrease down the dose. So check for the weight, blood pressure when she comes for the follow-up, physical examination you do, a relevant laboratory you should have, like she is on the estrogen and progesterone, so in between you should have the liver function test, etc. And if any particular side effect is there, that you have to check upon. And discussion on lifestyle strategies to prevent and reduce chronic diseases also should be done during their follow. Now, for what duration they should take up the treatment. So if it is premature menopause, so up to the natural age of menopause, which is 46.7, or you can say 46 years or 47 years in India. So at least up to that age, further continuation of therapy according to her symptom, if she is required, is there indication, then we will continue. Safety data for CEE plus MPA is 3 to 5 years, and ET safety data, only ET, not with the progesterone. ET safety data, as the data for 7 years, up to 7 years is available with 4 years follow-up. Extended use of hormone therapy is should be a shared decision between the women and the physician. Always you have to communicate with your patient that whether she has to continue her willingness, as well as your precision for the prescription should be there. For the stopping of the HT, if the patient has now do not have symptom, even you had decreased the dose, she is not having symptom, or the time period, long time period has elapsed, you want to stop MHT, patient want to stop MHT, then it can be stopped in two ways, abrupt as well as tapered. Any way can be done. I used to give them in my practice in the tapered way. When to stop treatment? If the patient is having some concerns, like some symptoms which were not earlier and then now appearing, like migraine appears for the first time, or if the earlier she has migraine and now the episodes are becoming frequent, the headache is becoming worsened, then you should stop. Blurring of the vision or any symptom suggesting of the vascular occlusion. If jaundice appears, if thrombosis, any feature of thrombosis appears somewhere, if there is significant rise in blood pressure, HT to be stopped 4 to 6 weeks before elective surgery if she is being planned for some surgery. So these are the conditions where we should stop. We can switch the regime, like there are so many regimes, so even the patient who are having in the perimenopause, they may be on the OCPs and now they wish to switch on the HT because now they are postmenopausal, so one can switch directly to MHT at the end of OCP. But how? She has to confirm that she is now menopausal. So by age we can assess, by serum FSH versus LH ratio, we can assess if it is more than 1, or FSH more than 30 international unit can be considered. But commonly the clinical judgment happens, and it is not always required that serum testing should be done for the switching of the medicine. Switching from sequential to continuous combined therapy, or one, if one question was there that sexual issues are there, then tibolone is a good option. So if the switching is required there, so it also can be done at the natural age of menopause, at least 6 months of amenorrhea. Means if 1 year has elapsed, definitely one can have. Otherwise, the 6 months of amenorrhea can also be considered for the switching of the regime. So these were basically for the estrogen progesterone combination, common combinations. What more we can have? The tissue selective estrogen receptor complex, TSEC, which is a combination of the conjugated equine estrogen and bezidoxifene. What is bezidoxifene? It is a selective estrogen receptor modulator and it works like progesterone. It is not progesterone, but it used to do the work of the progesterone. So endometrial protection without use of progesterone can be given where the progesterone is contraindicated. It is suitable for non-hysterectomized women, and the evaluation for the studies to up to 2 years with favorable safety profile is available. But in market, the TSEC availability is not available everywhere. For the Tibolone, the next talk is there, so I am not talking. Coming to the how to deal with the side effect when you have started with the oral MST. So there may be fluid retention. So restricted salt, adequate water intake, exercise, and diuretic can help. If the patient is having bloating, so little decrease in the dose or change the route, like transdermal. We can switch on transdermal. We can lower the progesterone that also causes the bloating, or we can switch to the another type of the progesterone or to micronized progesterone. One can have the breast tenderness, so again the decreasing of the dose and restriction of salt intake can help. For headache, switch to transdermal estrogen preparations. If the patient is having mood changes, so progesterone component can be associated with the mood changes. So one can lower the progesterone dose or switch from the systemic progesterone to the LNG IUS. That can help. That will decrease the side effects of the progesterone. For nausea, one can take the tablets at the night time before just bed, or switch to the transdermal estrogen. Now, what monitoring will be required? The blood pressure, lipid profile, breast examination, annual general evaluation, evaluation of therapy benefits versus risk. These all things should be checked. The duration of therapy, there is no fixed age. One can take MHT for 1 year, for 6 months, for 2 years, for 5 years. So depending on the need, duration of therapy can be kept. But the annual reassessment is definitely necessary. So basically, hormones keep the body in harmony. When it is not, so the hormone harmony can be created with crafting the right regime for every menopausal phases, especially if it is perimenopause, the cyclical progesterone or OCPs can help. In early menopause, the standard estrogens can help. In late menopause, the lowest possible estrogen and the continuous combined regime if the uterus is intact. Post-menopause with low libido, Tibolone is a good answer. Premature menopause, one can have standard MHT, or if cannot afford, then OCPs can work. For urogenital atrophy, definitely the local estrogens are the best one, though the systemic also gives a positive impact on that. So this was about in a nutshell for the oral hormone replacement therapy. Thank you very much. Thank you very much once again, Foxy and ICOG, for giving me this opportunity to be a part of this prestigious webinar. Thank you so much.
Thank you, Dr. Jyoti, for a very nice talk. I now invite Dr. Sandhya Khare for her expert comments.
Yeah, thank you. Thank you so much, Jyoti. I knew you are a great academician, but today you have proved that you are a brilliant orator also, though I have heard you many times earlier also, and you have a habit of giving a crisp knowledge. So you have covered almost everything, but only two things I wanted to tell you. I mean, no, not you. You know everything. The time is limited, so you may not be able to tell us, but I'm just telling to everybody that, you see, we have all seen that the pendulum of hormone therapy has been swinging to and fro every now and then. But of late, it's very clear that risk benefit is better assessed and formulated by doing the personalized dose to the patient. And nowadays, it's very clear that the hormone therapy given at right time is really useful. So, first and foremost, the myth should go away from us clinicians. We should be able to prescribe the menopausal hormone therapy with the view of preventing many problems, utilizing the this window of opportunity. So any perimenopausal women, when she comes to us, we can counsel her for menopausal hormone therapy, that if she develops any problems and lifestyle modifications, we can start telling her from then only, so that she improves her bone health. And secondly, I wanted to tell everybody that whenever we are giving the menopausal hormone therapy, we have to make sure our patients, they shouldn't have unrealistic expectations. It's not an antibiotic that they start within 3 days, within 7 days they are okay. No, that's why Jyoti has said that we call them after a month, so that the hormone therapy becomes effective in a month's time, then after 3 months, because by then it is fully established. So that's why we are calling them in that. And I liked her this saying that hormony can be achieved by crafting the right regimen, right dose, and everything right. So thank you so much for giving us a very precise information. Very good. Thank you.
Thank you so much, Dr. Sandhya.
Thank you, Dr. Sandhya ma'am. Now, next in our basket is a talk on Tebolon by Dr. Savita Tyagi. Dr. Savita Tyagi has been the past president, Agra Obs and Gynae Society. She has been the chairperson, Quiz Committee, Indian Menopause Society, scientific chairperson, NISMESCON, chairperson, Rural Committee, IMS, past president, secretary, Agra Menopause Society. She has been a master trainer for RAC in HPV. So welcome, ma'am. She will be talking on Tebolon. Hmm.
Yeah, I'm audible now, no?
Yes, ma'am, you're audible.
Yeah. So, Dr. Jyoti has discussed so nicely oral therapy, and one more hormone is there. And first of all, I'm thankful to ICOG committee, Dr. Swarna and all for making me part of this very prestigious webinar. And why we are talking about this HRD nowadays? Because now in new population, more educated women are there. They are more to enjoy life in any age, aware of MST. They know about the adverse effect of conventional HRT. They are sensitive to their health and social issues. And there is aware of global trend. And we all know what is the HRT, why we need HRT, because patients suffer a lot because of the hot flushes, night sweat, vaginal irritation, insomnia, depression. These all are the things which happens after the menopause. And what are these problems are vasomotor symptoms, urogenital problems. She may suffer from psychogenic problems, osteoporosis, coronary heart disease, and so many other things. So I will not discuss about what are the hot flushes. We all know about it, and around 65 to 85% of the women suffer from this menopausal symptoms of hot flushes and night sweats in 1 or 2 years in their climatic period. And we know somatotropic symptoms are in the form of atrophy of vulva, vaginal, bladder and urethral atrophy of the skin, and breast pruritus, pain on sexual intercourse, urinary incontinence, and dysuria. And vaginitis results from atrophy of the vaginal epithelium, leads to irritation, burning, pruritus, leukorrhea. Sexual dysfunction is there in the form of dyspareunia, vaginitis, vaginismus, physical discomfort, and loss of sexual interest. And Madam Dr. Neetam has already discussed about the urinary dysfunction and its treatment. And psychogenic problems may be in the form of anxiety, depression, insomnia, and headache. And one more many important problem is of osteoporosis. Many of the women are become dependent on their other people because of the fracture in their later stage of life. And this is occurs in the form of back. Patient may have to the start with back pain, decreased height, decreased mobility, increased factor of vertebral body, hip bones, ribs, and humerus, etc. Patient may also, if she's having early menopause, the chances of increase in the coronary heart disease, congestive heart failures are more. Also, the risk of atherosclerotic cardiovascular disease increases in the women who have early menopause or premature menopause. Other problems are marked thinning of the inkling of skin and atrophy of breast, low HDL cholesterol and high LDL cholesterol. Metabolic symptoms may be in the form of weight gain, osteoporosis, rising lipid, rheumatic changes, and tendency to gout. And surgical menopause is very much common nowadays. So many women are being hysterectomized in their late 30s, and these patients suffer a lot because of these, not only the vasomotor symptoms, but also having the bone problems and psychological problems, loss of libido, sexual dysfunction. That is very much common nowadays. Such many patients are coming to us. What is Tibolon? Tibolon is a tissue-specific hormone replacement therapy. Its tissue-specific activity may be explained by the interplay of several mechanisms, such as metabolic conversion of tibolon to compound with different biological activity, classical interaction with the receptors, specific local metabolism within the target tissue. Tibolon is a selective tissue estrogenic activity regulator. It has estrogenic, progesterogenic, and androgenic properties. After oral administration, it is rapidly absorbed and metabolized into 3 active metabolites, a delta, 4 isomers, and 3 alpha and beta hydroxy metabolites. The parent compound and these metabolites bind to a greater or lesser extent to estrogen receptors, and this is what gives tibolon its tissue-specific activity. Its efficacy, it's not only it's effective in the climatic complaints, it also improves the mood and sexual well-being, gentle symptoms, bone, and also it is safe on endometrium and the best in comparison to the HRT if it is only the estrogen is given. So tibolon is ineffective as a conventional HRT in relieving hot flushes and sweating. Tibolon improves mood and libido in postmenopausal women, has a beneficial effect on sexual well-being by increasing sexual desire, frequency of arousability, sexual fantasy, and vaginal lubrication. It also produces significant improvement in sexual enjoyment compared with conventional HRT with regard to coital frequency and satisfaction, and it improves the vaginal maturation index. It gives also effect on the urinary system. It gives estrogenic effect on the vagina. It improves vaginal atrophy and urinational symptoms. Tibolon increases bone mineral density by reducing bone turnover and prevents osteoporosis in the similar manner to estrogens. It has an estrogenic effect on bone, thus inhibiting bone resorption by reducing osteoclastic activity. BMD has been shown to increase at both at the lumbar spine and upper femur. This has been observed even with the half the conventional dose, that is 1.25 milligram instead of 2.5 milligram. Fracture efficacy has now been added to the list of tibolon's supplemented bone fibrinogen reduction in fracture risk, that is 50% is greater than would be predicted from BMD changes. So the effect of Dipolon, it closely matches the ideal product profile treatment of prevention of bone loss in postmenopausal women. Action on breast, Dipolon decreases the proliferation rate, promotes 17-beta hydroxysteroid dehydrogenase activity, a marker for epithelial cell differentiation, and increases apoptosis in normal human breast epithelial cells as well as breast cancer cell. Tibolon displays a progestinic profile on anti-estrogenic action in the breast cell. Tibolon and the endometrium, tissue-specific endometrial conversion into gamma-4 metabolite, progesterogenic dominant effect on the endometrium, no endometrial stimulation, and no withdrawal will occur if the tibolon is used. So on the lower genital tract, both karyopyknotic index and maturation index improves in women who are on tibolon, thus reversing the vaginal atrophy that takes place after the menopause while maintaining an inactive endometrium. As it is a tissue-specific steroid with estrogenic, progesterogenic, and androgenic activity, in vitro studies show that tibolon inhibits the production of estradiol in breast cells. Tibolon has an effect on the breast that is different from the that of estrogen. Its effect on the lipid profile, It stimulates cardiac output, blood flow, vessel relaxation. It stimulates fibrinolysis, no effect on coagulation. Decreases total cholesterol, triglyceride, and lipoproteins. Also decreases LDL and SGL2. Studies have also found an decrease in fibrinogen and factor VII activity, increase in anti-thrombin 3 and plasminogen, with an overall trend towards increase in fibrinolytic activity, tibolone. So it has mixed effect on cardiovascular health, so should be used with caution, especially in postmenopausal women after proper risk assessment like we do in the when we are prescribing the HRT. So tolerability has a different effect on breast tissue compared with the conventional HRT. The incidence of breast cancer is lower, but we can't use it in the breast cancer survivor or the patient of having the family history of breast cancer. It shows a high amenorrhea rate and significantly less irregular bleeding than seen with the conventional HRT. What it is a better than in that form over the HRT. So it has active metabolites, which I have discussed already. So 3-alpha hydroxytibolone estrogenic receptor attacks on the estrogenic receptors. These are present in the bone and vagina, so it decreases bone turnover, improves bone density. In vagina, it improves vaginal dryness and reduces the dyspareunia. While 3-beta hydroxytibolone is also there on the estrogenic receptors within the bone and the vagina. The D4 isomers are progesterone receptors. They are present in the endometrium, so there will be no endometrial proliferation. These androgenic, while the D4 isomers, the androgenic receptors are there in the brain, so it improves the libido, increases sexual well-being, and CVS stimulates cardiac blood flow, vessel relaxation, and reduces serum HDL. So it has been seen that tibolone can safely be given to treat the woman with climatic symptoms. It enhances mood and sexual well-being, a low incidence of breast tenderness, no increased mammographic density. Although on cardiovascular parameters, beneficial effects are not proven, so it is patient is having the cardiovascular risk should not be given. There is no endometrial proliferation because it also has the progesteronic activity, treats vaginal atrophy, and prevents postmenopausal bone loss. It does not stimulate the endometrium, shows any stimulation of the breast. No increase in mammographic density has been observed. Dose is 2.5 milligrams, the standard dose, but can be titrated according to the need of the woman and can be kept as low as 1.25 milligram. It is given orally. So it's as effective as conventional HRT. It enhances mood and libido in postmenopausal women, has a beneficial effect on sexual well-being by increasing sexual desire. Also treats vaginal atrophy and improves urogenital symptoms. It is as effective as conventional HRT in preventing bone loss in postmenopausal women. Increases bone density in osteoporotic women. It has a different effect on breast tissue that I have already said. So a patient has suspect contraindications. A patient has passed or suspected breast cancer, known or suspected estrogen-dependent malignant tumors like endometrial tumors, undiagnosed vaginal bleeding, previous or current venous thromboembolic history is there, or there is active or recent arterial thromboembolic diseases. Patient is hypersensitive, porphyria. These all are the contraindications to use the tibolone. Thank you. Thank you so much for giving me this opportunity. I think I have completed in my time.
Yeah, thank you, ma'am. Thank you for finishing in time. I would request Shanti ma'am for her expert comments on this talk on tibolone.
It was indeed a very lucid talk by Dr. Savita Tyagi. She has nicely stressed on the point that tibolone is a tissue-specific hormone, acts like an estrogen on vagina and bone, acts like a progesterone on endometrium, hence there is no endometrial hyperplasia, and acts like an androgen on brain, muscle, and to a certain extent on the heart, so that mood elevation is there, muscle strength is maintained, and also coagulation profile is not altered. And of course, she has also clearly mentioned about contraindication, like liver disease, porphyria, and previous history of thromboembolic episodes, any stroke, and history of breast cancer. And generally, we do not start only after 1 year after the final menstrual period. It's started. So, a very nice presentation. Thank you very much.
Thank you, ma'am.
Thank you, madam. Thank you so much.
Now coming to our next talk on transdermal MHT, we have another gem from the beautiful city Agra, Dr. Aarti Gupta, who is a dynamic and accomplished healthcare leader with extensive experience in gynecology, menopausal health, and public health advocacy. She has been the Vice President, Indian Menopause Society, Vice President, SOFC, President, Taj Doctor Association. She has done many activities, has published many papers, and has been the editor of Poise Mind magazine, and has done many public activities also. So welcome, ma'am. Over to you for the next talk.
Thank you, Aditi. Thank you so much.
Again, asking the previous speakers to please answer the questions in the chat box.
Please unmute. Aarti ma'am.
Wait a minute. Okay. Now you can listen me? Hello?
Yes, ma'am.
Okay, thank you. So I am Dr. Aarti Gupta from Agra, and my talk is on the transdermal hormone therapy. And as all of us know, the size of the problem is not that small. Approximately 2.2% of the women of less than 40 years, that is, they are suffering from the premature ovarian insufficiency, and approximately 16.2% are experiencing early menopause. And all of us know that menopause is diagnosed when we are having the 12 months of the amenorrhea, and FSH is not really required for the diagnosis of the menopause, but the FSH should be done in the patients who are at the age of 40 to 45 years to confirm is this patient is a menopausal or there are the other symptoms. And the other women in which the FSH is required are the patients who have the hysterectomy with bilateral salpingo-oophorectomy. These are without bilateral salpingo-oophorectomy. These are the patients in which we have to find out if whenever they are going to be the menopausal, so we can start the hormone therapy if patient required. And the third most important part, why which I have taken this point is this: women of less than 40 years of the age with amenorrhea or with infrequent periods for 4 months, or in whom we suspect there may be the POI. So these are the patients who are of less than 40 years and they are having the amenorrhea of 4 months, or they are having the scanty periods. So these are the women in which we should go for the FSH, and we should diagnose these patients timely so that we can start the hormone therapy and we can save their life and we can maintain the quality of life of these women. The FSH should not be done in the women who are taking the oral contraceptive pills. Either we shift to the progesterone only pill, then we can do the FSH, or we have to stop the oral contraceptive pills for approximately 1.5 months, then we can go for the FSH. All of us know window of the opportunity we should use within 10 years of the menopause or within the 60 years of the age, but now there are the newer studies, latest updates that you can even use after the 60 years of the age, but you have to do the risk benefit analysis, then you can, and you have to discuss to the patient, then you can use the hormone therapy. We have already discussed the oral route, that is the MST, which I told by Dr. Jyoti, and the Trivalon also by the Savita. Now I am coming on the transdermal route. The indications of the transdermal routes are deranged lipid profile, in which specifically increased triglyceride, hyperlipidemia, or increased CRP, C-reactive protein. The patients with migraine with aura, diabetes, if well controlled, we can use the transdermal hormonal therapy. It is not advised in the patients with diabetes who are having the end organ failure, or in the patients with diabetes type 1. We should have the controlled hypertension to prescribe the MST, transdermal MST, but it is contraindicated in patients of the coronary heart disease. We can prescribe in existing gallbladder disease, in obesity, smoking, even in the patients with previous VTE. Now we can prescribe the transdermal hormone therapy. In the patients of the varicose vein and patients with the bowel disorders, in bowel disorder, especially in the irritable bowel syndrome, we cannot give the oral hormones because the absorption level will be difficult to assess and the effect will also be difficult. So we should not use in these patients. We should use in the patients of the sexual dysfunction because it has a very less effect, almost nil effect on the sex hormone binding proteins. That's why the sex hormone binding globulin. So that's why the testosterone will not combine with the sex hormone binding globulin, and the free testosterone available will be more in cases of the transdermal hormone therapy. We should use in the patients of the Parkinson's disease, in the patients of the post-transplant, renal transplant or other transplant, and we can use in the patient of the thyroid. It's not a contraindication for the thyroid patient. Now, what is the comparative effect of the oral versus the transdermal estrogens? As we can see in the pharmacokinetics, the oral estrogens, the serum levels are always ups and downs. Never there are the steady levels, while the transdermal estrogens will have a steady level, that is the constant level in the plasma. The inflammatory marker, for example, C-reactive proteins, oral estrogen increases the synthesis of the CRP, while transdermal is neutral. On the lipid profile, there will be the increased triglyceride, increased HDL, which is a good point, but decreased LDL. On the lipid profile, it has a good effect except the triglyceride, while the transdermal estrogens, they decreases the triglyceride and they have the neutral effect on HDL and LDL. That's why transdermal are better. Blood pressure is increased with oral estrogens, while it will decrease with the transdermal estrogen. This is also a plus point. Insulin-like growth factor 1, may lead to decreased lean body mass and increased body fat, while transdermal estrogen is neutral. Sex hormone binding globulin, I have told you, it is strongly increased, which ultimately lead to the less free testosterone, while the transdermal estrogen increases minimally the sex hormone binding globulin. So free testosterone available is more, so sexual functions are less affected. The clotting protein synthesis, that is hepatic enzyme induced, may increase risk of the venous thromboembolism, while its transdermal estrogens are neutral, no increase in the risk of the venous thromboembolism or has a low risk. These all are the studies which depicts that the risk may be lower with the transdermal MST containing natural progestogen like dydrogesterone and micronized progestogens. The types of the medications available are the first is the transdermal gel. All of us are well known. It also contains 17 beta estradiol applied either on the arm, leg, or thigh. It should be applied daily. It maintains plasma level between 60 to 80 picogram per ml. It also improves the collagen content and may avoid skin wrinkles if applied topically to the affected area. Subdermal estradiol implants, these are of 3 types. They are the estradiol, they are 25, 50, and 100 milligram. They are inserted subdermally in the anterior abdominal wall using local anesthesia by a minor surgical process and useful specifically in the stectomized patient. They are effective for 6 months. We have to repeat it again after 6 months. Maintain the level at 50 to 60 picogram per ml. And in selected cases, even the testosterone implant can also be inserted for loss of libido cases. Now, this is the preparation of 17 beta estradiol. All of us know the estrogel or estabet gel is available. 1 pump is equal to 1.25 gram of the gel, and 1 pump contains 0.75 milligram of estradiol. The starting dose is 2 pumps per day, that is 1.5 milligram per 2-meter dose. For mild symptoms, 2-meter dose will be enough. What points we should consider whenever we are applying the local estradiol gel? The first thing is this, कि we should discard initial 2 to 5 pumps as written on the indications of the medication, because it may be harmful to use initial 2 to 5 pumps. Wash your hands with soap and water before and after each application. Select a clean, dry, unbroken, and non-irritated skin, specifically in the upper arm, shoulder, or thighs. You should apply it after bath, either in the morning or in the evening. After applying, no massage or rubbing should be done. And apply sunscreen or any lotion to that area approximately after 1 hour, because applying before that can affect its absorption. Wait for minimum 5 minutes before covering the area with the cloths. Avoid swimming or washing for 1 hour. 1.25 gram per day for hot flushes. Apply on the same time. Suppose you missed one dose. If you miss a dose, skip the missed dose. Don't apply extra gel at least for 12 hours. Don't use extra gel to make up or dose. Preferably approximately 2,500 rupees in India. Maximum dose is the 3-meter dose. That is equal to 4.59 milligram. It should be used at the forearm, and each spray contains 1.53 milligram of the estradiol. One spray delivers. If you are using 1 spray per day, then it will be used for the 56 days. If you are using 2 spray per day, then it will be finished in 28 days, or 3 spray per day, then it will work only for the 18 days. I can show you a small video here if you want to see. It will give you all the points regarding this.
A quick demo on how to use your Lenzetto spray. This is estrogen only and has
आवाज आ रही है आप लोगों को?
progesterone. If you have a
Yes, ma'am.
Sound आ रही है वीडियो की?
Yes, ma'am. Ari.
Okay.
If you don't have a womb but have had a background history of endometriosis, then you need this estrogen and progesterone as well. To apply your daily dose, take off the plastic cover. I've lost the plastic cover because I've been using this for so many times on so many teaching cases. But what you do is then hold the container upright and rest the plastic cone flat against the inner forearm. Press the button down once fully. If you're taking more than 1 dose, so the maximum dose you can have is 3 pumps, you just move that along, making sure that you're not overlapping on the arm, and press again in a new place. You can also apply the Lenzetto spray on the inside of your inner thigh, holding it down, pressing the button for 1 pump, then moving it along if you need more than that for 2 pumps, and then further along onto a new space for 3 pumps. 3 pumps is the maximum you can have. Make sure that the skin where you're going to apply the Lenzetto spray is clean and dry. The Lenzetto spray can be used at any time of the day, but it's best applied at the same time each day for consistency. Ultimately, the best time to use Lenzetto is whenever it fits into your routine, as long as it's applied consistently at the same time every day and you remember it as well. So you've applied your Lenzetto spray. Let the spray dry for at least 2 minutes before getting dressed, and at least 60 minutes or an hour before bathing or washing. If you get the spray onto other areas of your skin, like your hands, wash that area of the skin with soap and water right away. You don't need to massage or rub the Lenzetto spray into the skin. Remember, alongside this, if you have a womb, you'll need your progesterone component, and that could be progesterone oral capsule or progestadine, which are synthetic progesterones, or a Mirena coil that also acts as the progesterone component. As always, if there's any questions, leave them below and I'll answer them. A quick demo on how.
Now I'm coming on the transdermal patch. Transdermal patch contains 3.2 milligram of the estradiol, releases 50 microgram estradiol in 24 hours, changed twice weekly. Advantages are same. First, it avoids the first pass effect of hepatic metabolism, directly released into the systemic circulation as estradiol. Higher blood levels of most physiological estradiol are achieved. Combi packs are also available containing estrogen and progestogens, and can also be used for combined hormone therapy. And it should also be changed twice weekly. Patches applied on the same either arms, legs, or thighs. What are the disadvantages? Disadvantages are it's costly, variable absorption is there, less suitable environment, tropical climate, skin reactions are there, including the pruritus and irritation, and especially with alcohol-based patches. Now, non-alcohol-based patches are also available. I have told you the patients with the sexual dysfunction, the transdermal estrogens are better because you have the more sex hormone binding globulin free, less effect on the sex hormone binding globulin, which causes the more free testosterone. So it's better for the sexual function. The available preparations are the Estradam MX50, that is a transdermal patch, not available in India. And there is the 17 beta estradiol dose is 0.025 milligram for vesicovaginal atrophy. The role of testosterone. Primary indication is diminished sexual desire that causes the affected woman to experience significant distress, that is hyposexual desire disorders. The androgenic side effects of testosterone therapy are dose related. Large placebo-controlled RCTs, transdermal testosterone in appropriated doses has no adverse cardiovascular or metabolic effect or effect on the endometrium. So you can use as depicted by the RCT, but abhi, there are no guidelines to prescribe this drug. The intravaginal or with vaginal estrogen has been shown to improve dyspareunia, sexual desire, lubrication, and satisfaction. Beneficial effects have been seen with administration 3 times per week. Doses 1% gel of 10 milligram of androgel available in India. Seron gel 5 to 10 milligram. Rub in upper arm OD for 6 weeks. This is also available in India. The other preparations are there may be the vaginal estrogen ring. It contains 2 milligram of the estradiol, is worn vaginally for 30 days and is then replaced every 30 days. It also acts on all the symptoms, dyspareunia, urogenital dystrophy, and urinary symptoms. Intranasal estrogen is also available, but we are not using because of the nasal pruritus and sneezing, and usual dose is 300 microgram for the faster action. Now, the other preparations are the vaginal estrogens I am taking here in very short, though they are not transdermal, they are used vaginally, and they are working through the mucosa. And the most important point for the vaginal estrogen is they can be used at any age. Adverse effects are rare, does not require progesterone, and does not require endometrial surveillance. Low dose vaginal estrogen may provide benefit for the urinary symptoms also, including prevention of recurrent UTI, overactive bladder, and urgent continence. You have seen so many times there are the patients in the OPD who are coming to you with the recurrent UTI and they are not responding at so many physicians, and at last they are coming to you. And you are one of those that you should diagnose that this problem is because of the vaginal atrophy and all the tissue which is going atrophy because of the hormone deficiency. And these are the patients which are relieved by the local estrogens. So that is a very important point which we should always remember. Hormone therapy does not have any FDA approval for the urinary health indication. Vaginal estrogen in low doses improves the sexual functions also in the postmenopausal women. According to the Indian Menopause Society in 2020, urogenital symptoms respond well to estrogen. Vaginal route of administration coats with the better symptom relief. And the third thing is the long-term treatment is often required as symptoms can recur on cessation of the therapy. Systemic risk have not been identified because the dose undergoing in the systemic circulation is very less or almost nil. Endometrium surveillance, I have told you, is not required. And the drugs which can be prescribed are the conjugated equine estrogen cream or estriol cream or estradiol cream. Regular follow-up examination can be done every 3 to 6 months. Normally, the follow-up is not very strict follow-up is not required. Sooner the better. जितना जल्दी आप इसको prescribe करेंगे वो patient के लिए बहुत अच्छा है. And how long it can be continued? The latest guideline says that you can continue it even for the longer time, and the black box warning is going to be removed very soon from preparation. I think it has been removed also in the latest guidelines. Preparations are the Pimerin cream, conjugated equine estrogens, All of us knows dose is the 0.5 to 2 milligram for 15 days. Then every alternate day for 2 weeks. Then as you required once in a week or as you feel. Evalon cream is the dose is the same. Doses is the half to 1 gram per day. You have to give in the same way as you are giving the Primarin cream. And the third dose is the estrase, which contains the estradiol. Dose is 2 to 4 gram OD for 2 weeks. Then twice a week. Then followed by one time to 3 times in a week as you required. Now, what are the requisite? How you will use it? Time to vaginal estrogen cream is at night, increases effectiveness and minimizes the leakage that can occur during the day application. Applying the cream while lying down allows it to be absorbed while gravity is not an issue. Apply daily for first 1 to 2 weeks, then again twice a week, then once in a week. For the recurrent UTI, apply gel on outer part of the vagina by finger, facing the finger anteriorly towards the urethra. Men absorbs vaginal estradiol during the intercourse, whereas intercourse reduces the estradiol absorption in women. The serum levels are only mildly elevated in men. If it is possible that long-term exposure could cause feminizing symptoms. Another drug is the isoflavone gel, which is available, and this is a phytoestrogen gel. The whole ointment, whole tube is used once, which contains 5 milligram of isoflavone, and it should be used every third day. Once in 3 days, it should be used. Now, when to stop the MST? Dr. Jyoti has already told you that whenever there is the rise in the BP, there is sudden headache, appearance of the jaundice, breast tenderness, chloisma, and generally all these symptoms generally subsides in up to 1 to 3 months. If not subside, then you are supposed to diagnose the patient and you have to see the patient. The decision to continue in the HRT should be highly individualized, considering ongoing symptoms, benefits, and evolving risk factor. No arbitrary fixed duration, not limited to 5 years or until age of the 60 years. Even you can use after, as I have already told you, after seeing the risk-benefit analysis, what is the benefit and what is the risk. Regular reassessment, that is minimum annual reassessment, should be done after doing the initial assessment. Gradual tapering of the drug should be done. Decrease the dose by 25 to 50%. There will be recurrence of the symptoms in 2 to 4 weeks. If symptoms persist for 6 to 8 weeks, then we will come back to the original dose. Or if the symptoms doesn't come, then again you can reduce the dose after 6 months to 1 year. These are the last slide, take-home messages. The personalized care should be done. Timing matters. Window of opportunity, you can start the treatment. Ongoing monitoring should be done and we should stay updated. Thank you. Thank you so much.
Thank you, ma'am. Thank you for such an elaborate talk. As Dr. Geeta is traveling in train and she does not have a network connection, I would request Dr. Sandhya Khare to quickly summarize the key points. Dr. Ragini is running short of time and she has to be back by 7. So we'll quickly start the panel after this.
Yeah, thank you so much,
I will leave
Dr.
by
Aarti
7.
Gupta.
I will leave by 7 p.m. I'm not coming back. I'm leaving by 7.
Yeah, thank you. Thank you very much, Dr. Aarti Gupta. Your presentation was excellent and you have focused everything very well and explained very well. In fact, your video was
Ragini
also
ma'am, you can
practical. Yeah, so I'll request Dr. Ragini, as you know, Aditi is going. So let the flow
No,
go
not.
because Dr. Aarti did wonderful job.
Thank you, ma'am. Thank you so much.
Please just play the next slide. So we are quickly coming to the flag end of the session, which is the panel discussion on cosmetic gynecology, and it will be moderated by Dr. Ragini Agarwal ma'am, who is the General Secretary IMS 2025, Founder Chair Aesthetic Health Committee IMS 2020-22, and Joint Secretary IMS 2023. Ma'am doesn't need much introduction. Yes, she has many publications to her name, many awards. So ma'am, I welcome you to start the panel. And
please introduce all the panelists also.
So these are the panelists, Dr. Kripa Bhagat, and she's a laparoscopic surgeon and vulvovaginal aesthetic surgeon. And she has a fellowship. And then Dr. Shivani Shukla Jain. She is a fellowship in cosmetic gynecology, Dubai. Then we have Dr. Beenal Shah, who is the Joint Secretary, Indian Menopause Society. Next slide. Dr. Poonam Mishra, who is the president of Indian School of Aesthetic Gynecology. Dr. Riddhi Shukla, she's again a practicing she's a pioneer of aesthetic gynecology in Gujarat. Next. Dr. Geeta Vineet, she's a cosmetic gynecologist in Calicut. Then Dr. Tulsi, who is practicing in Thrissur. She's a FMS and fellow ART. And then last but not least, Dr. Jamna Devi, who is a senior consultant at Yashoda Hospital, Sikandrabad, and also a medical legal advisor. So please, ma'am, welcome all the panelists. And Dr. Poonam Mishra, ma'am, slide. She needs no introduction, but Dr. Poonam Mishra, a big name and fame. And yeah, ma'am, I've introduced you earlier. Thank you. Welcome all.
So thank you very much for this invitation. And I'm so happy to see the Sangam of the Foxy and the IMS today in a real way. Although we all are Foxian, but some of us are more devoted toward the menopause society. So all the delegates who has listened today must be had a good time with the new topics and discuss very properly. So coming to my own panel with the great names like Poonam, Riddhi, Vinal, then some young dynamic girls there also, Kripa and Shivani Shukla, Dr. Tulsi, and my dear friend Jamna. So friends, the topic was the cosmetic gynecology in midlife. What do you mean by the cosmetic? What the word cosmesis is? The real English version of the cosmesis. Anyone? I'm not doing a panel discussion like a PPT because nowhere in the world is done by like that. I'm a moderator and you are the expert. So please, any one of you.
Yeah, cosmesis basically is something like which is pleasing and kind of gives a pleasant view. So by looking at it, it's having a pleasing view and presentable. So I feel that that is how we can take cosmesis. But at the same time, I would say that when we talk about cosmetic gynecology, we are talking about
Binal,
the looks as well
please,
as the function.
please, Binal, don't go beyond this. I just want to understand the word cosmesis because we are all using the word cosmetic gynecology. When you word using word urology, we talk about only urology. So, yeah, youngsters, please tell me. You are all written your cosmetic gynecology. What you will all do in the midlife in a cosmetic gynecology? What you're planning to do with your patient? Anyone? Yeah, Tulsi, anyone?
Ma'am, all of our patients in mid-size, like menopause and perimenopause, after deliveries, they'll be having a lot of other issues also, like the vaginal laxity, lot of vaginal dryness, and recurrent urinary infections like the GSM, genital urinary syndrome of menopause. So we can help them through cosmetic gynecology.
So this is cosmesis. You are beautifying these things.
No, of course, it needs functional aspects. So it's not just about cosmetics.
So
It's also about the functional aspects.
When we talk
90%
about
of
the
the
ENT,
patients that we get are functional patients. We hardly get like 10% is for cosmetic reasons.
so
Can I-
basically what I want to say, when you talk about the ENT, ear, nose, throat, in ENT, you can't say that it is the only ear and I work for nose also and work for throat also. So why this you use this word of the cosmetic gynecology? I never understand. First, I thought I will ask about the vulval bleaching. I will ask about the labiaplasty because of the Barbie doll appearance. So should I go for the functional thing? Should I ask about the functional thing
No,
or
I
only
think-
cosmetic?
No, cosmetic gynecology is an inappropriate word for regenerative gynecology. I think it is a non-medical indication and it is more of body image and social pressure. It's not for regenerative or function. So we have to, I think, delete this cosmetic and start, talking about as functional and regenerative gynecology rather than cosmetic gynecology.
So thank you, Jamuna. Actually, only this message I want to say everyone for last 5 years. Don't use this misnomer, and otherwise it will be fixed in the mind of the patient also. And you are working as a real gynecologist. किसी के पीछे से बहुत आवाजें आ रही हैं, प्लीज
पूनम
अपने
मिश्रा
पीछे
मैम।
वालों को चुप करा लो. So what happened with this cosmetic gynecology business? Your patient is confused, your fraternity is confused, because many of them said, यार patient तो कौन आएगा cosmesis के लिए हमारे पास? Why should we support this subspecialty? And this wonderful subspecialty will gradually die because we are not getting any support from any regulatory bodies, any government, and this will create a problem in future. So please remember, we should stop using this word, and this is not an appropriate word at all. So my next question is, tell me if we talk about functional and the regenerative word, which is the apt for specifically the midlife, what are the problems you are going to handle, Dr. Poonam?
Because
What
in
are our
midlife
unspoken
patients,
problems?
I know. Yeah, most of the times the males in the midlife come with the problems of GSM related with just like genitourinary syndrome of midlife. Most of the times, dryness of vagina, bruises and cuts are there, and they are leaking, they are having stress urinary incontinence, urge, and most of the time there are mixed urinary incontinence. Many patients come with lichen planus-like symptoms, intractable vulvovaginitis. They are getting the treatments from here and there, and every time they are getting again and again the infections with them. And yes, few patients come for the laxity treatment, not much, but yes, many times females come in their midlife also that they are lax and they are not having their proper sexual life. So they want some kind of tightening as well as like the leakages also. When we treat SUI, we are also tightening the vagina.
Poonam, people are complaining that your audio is not very clear. I don't know.
Oh, ma'am, I am at the airport. I am in Bangalore. Maybe
Okay,
some
okay,
sounds are there in the background.
okay, okay,
Yeah.
okay. So carry on, please. So basically, what Dr.
Yeah.
Poonam has
So,
said,
so basically, these
what Dr. Poonam has said, and Dr. Chilappan, she has said that we have to focus on the GSM patient who are maybe refractory with the estrogen, or with the time they are not able to use the estrogen. Maybe they are not fit to take the estrogen. There, the role of these regenerative, functional, and aesthetic medicine will come in a big way. So, what has changed in last few years? Any other problem? Anybody want to say ki not only GSUM, there's other thing also.
Vaginal laxity is also one of that, which affects
Yeah,
their
sexual dysfunction also,
relationship.
ma'am.
So, do you think the addressing vaginal laxity, Dr. Shivani, आप अपना जैसा on करें फोटो, and Dr. Riddhi, दोनों लोग नहीं हो यहाँ पर, कि क्या vaginal laxity को address करना बहुत जरूरी है?
Oh,
It is
yes,
must to address it.
ma'am, definitely, ma'am.
Salt,
Once a
yeah.
patient is coming to us with the complaint that actually she's having some complaint of vaginal laxity, which is affecting her sexual health as well, a relationship with her partner, her husband. And when she's coming with the complaints, and now we have, with the advent of functional, aesthetic, and regenerative gynecology, so many treatment options that we have available. So we should be offering these treatments to our patient in the form of a lot of energy based devices that are available.
आएंगे वहां तक आएंगे तो मतलब Dr. Shivani has focused one thing, that is the sexual health in the midlife. So midlife, with the midlife, your life is not finished, but you really, it is a time when you are free of your responsibilities and your children are gone away, you and your partner is together, and you have more time. Not only that, in this era of the divorce, second marriages and third marriages and the late marriages, many a time it is a woman who is around 48, 50, she is getting married and she is little apprehensive. She will come to you and ask for that. Look, doctor, I have 2 vaginal delivery with my first partner, and now I am getting married again, and how my partner is going to be happy with me. So it's very important things, but it is there since ages. Because the first patient which I handled in 1991 for vaginal laxity, So from where my journey has started, so just I want to ask anyone, one of you, whoever want to take, what has changed? What has actually changed the scenario? Why today we are discussing it so openly?
People are more concerned about their sexual life these days, and they're opening up. The quality of midlife is, of course, dependent on sexual life. So we are getting more patience for that.
Also, women have paying capacity, ma'am. Now, I think women are free to spend money on themselves and time on themselves. So they are coming forward to our OPDs.
Yeah.
Also, there is a lot of awareness amongst all the patients as well. So they're coming up with these complaints.
With all the social media, I think all of us are talking about it.
Yes.
And I think a lot of OBGYNs are also giving awareness lectures, which are, causing a little stimulation to the woman. And because of that, a lot of women are becoming aware and empowered with this knowledge.
Yes, these are the things which has come up with the revolution, after the revolution, which was happened in 2010. Basically, pap smear was there since ages, but when it has become the name of on every lips, when the injection came. Because with the injection, companies came, their money came, and everything has changed. And that has happened with the energy-based devices. What Shivani wants to say, when these energy-based devices came in the market, the first, the Mona Lisa, which has first uh, machine which has come in the market, that is a carbon dioxide laser, and its main indication is a regeneration in the midlife. It was not a so-called vaginal regeneration in the young woman or tightening. So from there, the influx of the money has changed everything, and the cosmetic gynecology per se has arrived in the world. And we also use the same word, but the sooner and later, I came to the conclusion that absolutely till we are talk about the cosmetic gynecology, we are literally demeaning a beautiful specialty, which is the need of R. So what is the EBD and how it works? रिद्धि कहाँ है? रिद्धि नहीं दिख रही मुझे कहीं भी.
Must be busy
Ah,
doing surgery.
anyone?
Riddhi, she left for an emergency case. She had messaged.
Okay. Any one of you can take this question.
Energy-based devices can be classified as lasers, radio frequencies, HIFU. In these lasers also we have CO2 lasers, diode lasers, then the RF, then the HIFU, including the HIFM chair. All these things we are using in.
So basically, energy-based devices are electromagnetic waves. And one of the spectrum of the electromagnetic waves is used in these devices. And what is electromagnetic wave is basically a light. So when we channelize the light in certain way, it give us something whatever we are talking about today. One is laser, as Dr. Tulsi has said, and the laser which is really first came in the market is a carbon dioxide laser, and another which came after that is a erbium YAG laser. And diode is very popular nowadays because it is comparatively cheaper, but it's better laser for the vascular, not for the place where it is more of the water. Because for the laser, what you need for a laser? To act laser, what you need in a body?
Chromophore.
Chromophore. And
Chromophore.
what is chromophore in the water, in the vagina?
It is water.
Water. So the best absorption of the laser of carbon dioxide and the erbium YAG laser is in water. Now, this is basically the theoretical question. Now coming to the case-based. So everybody will understand it is a specialty why every gynecologist at least should know and try to practice. And second thing, after EBD, what has come is the adjuvants like
PRP,
which has changed the scenario. So anybody who can think of not investing the money in the lasers or in the RF on the HIFU till you have a bulk of the patient, at least you can use the PRP. It's very simple, very easy. So a 68 years woman came to OPD with vaginal dryness and itching. What will be your diagnosis and what are newer treatment available? Anyone?
She can be considered as she's having.
Vaginitis.
Yes.
Go ahead,
This
Jita.
looks like atrophic vaginitis.
The word has gone from the word. The
She's
word WORLD word does not use this WORD word, atrophic vaginitis.
Okay, ma'am.
It is a word, genitourinary syndrome of
Urinary syndrome,
menopause.
GSM of menopause. Yes.
Give the dignity to the woman.
Yes, sorry.
Yes.
So yeah, GSM, we can give her local estrogen, lubricants, advise her lubricants when she's having sexual intercourse, give her moisturizers. Also, when there is, generalized lot of atrophy, I would start her on PRP injections and later on use energy-based devices.
Would you
And
not
earlier,
like to
PI is...
examine?
Yeah, that's
Huh?
what I was about to say, that physical history is very important. Physical
Yeah.
examination is very important to rule out the contraindications, especially the acute infection, undiagnosed cervical or vaginal lesions, or any malignancies, or there was any implants, mesh plasty, or if they have used some other mode for regeneration, or if they have undiagnosed medical conditions and diabetes. Uncontrolled diabetes also is one of the contraindication for this. So history and examination is a must.
So Dr. Gina, चलिए आपका GSM था and you want to use, what do you use as a EBD? What you have as a EBD? RF, diode, carbon dioxide, what you have?
Are you asking me, ma'am?
Yes, Jita.
Okay. So we have both CO2 and diode lasers
So,
and
okay. So
HIFM chairs.
what
We
you use in this
diode.
woman?
Ma'am, when there is severe atrophy, I don't use EBDs. I give PRP first, and once the epithelium develops and little, it's normal, then I use EBDs. I don't use EBDs initially, at least for this patient.
So why don't you use a priming of the estrogen in that patient?
Yes, ma'am.
Why don't you use the priming with the estrogen in these patients?
Yes, we give estrogen, ma'am. The first treatment is estrogen for these patients.
Yeah. So what message I want to give, these lasers are not any magical wand, and we are not just thinking, I have a laser, I will only use a laser, I will not use a vaginal estrogen. The vaginal estrogen is always the first line treatment. Like a patient of the fibroid, you don't jump directly for the hysterectomy. You apply everything. There's a combination also. You can go with the combinations also. So here also we go with the combination. Beautifully, Dr. Jita has said, if it is too much atrophied, she doesn't want to use a EBD because what it will do. Why you don't want to give it? Shivani, why she will not give a EBD in this patient? In a very atrophic parchment-like vagina, why should not we give
Because
the...
basically all the energy based devices, they release energy, they are ablative as well as they have thermal energy, which will further damage the vaginal mucosa. So first we need to prime it up with a local estrogen so that at least the vagina becomes healthy, and then over and above that we can use our energy based devices which will work.
But in menopause, I think it is the skin is very thin and the
Yes,
layers
that's
are
what
very thin.
will
And
burn. The
that is,
patient will have a
yes.
lot of symptoms. If we are using some fractional CO2, then the patient will not be able to bear the pain, even with a local anesthetic agent. So at least
Binal, your input, and Poonam, then your input as a
Basically,
very senior person.
what is also
Yes,
important is
ma'am.
to improve the vascularity of the local tissue. And so that is why, priming with like estrogen, giving a hormonal, local hormonal supplement would be better before giving the energy-based device.
Okay.
That will give a more, adequate response to the energy. Once you have
Now it
had
is...
proper hydration or proper moisture is there in the tissues, then you get the proper response of the energy-based device.
Okay. Poonam, your input as a very senior person. And another thing I want to add in it for you, that patient cannot use the estrogen supplement because she is scared. She has a E positive breast carcinoma survivor.
Yeah.
So,
Madam, the fact is that in such cases, CO2 laser does wonders because it is ablative one. Small pinpoint ablations are there. The complete re-epithelialization is there. So we use CO2 laser along with PRP. And I give in between, like monthly CO2 laser applications, and in between, after 15 days, I call for PRP application. These days,
so
stem cells,
how do you do the
exosomes, they
PRP in the
all
vagina?
are available.
How do you do the PRP in
Ma'am,
vagina?
complete rejuvenation. Yeah, the PRP is taken in insulin syringes with long needle, and the Cusco's speculum I insert, and the two lateral walls which are popping in. I'm so sorry, the background noise is there. So the popping in lateral walls, I inject at 1 centimeter distances from interior to posterior, complete rejuvenation of the whole vagina. And then I rotate the Cusco's, then interior and posterior walls are popping in. And in that also we give the PRP, and excellent results are there. Patients are coming back and they're asking for the treatment again. That confirms that they are getting benefits.
So it's very clear that we have a newer modalities with us, and as far as our experience go, for almost I can say more than 12 years with the lasers in the vagina. It is wonderful thing. But till we will continue the cosmetic gynecology, we are not going to support it by anyone. So next question is, a 54 years woman complain of vulval itching, not the vaginal itching. And on examination, she has a silvery white patch extending up to anus. What will be your diagnosis and how you will treat her? Dr. Jeeta, no, sorry, क्या नाम था? Dr. तुलसी देवी, वो लिख रही हैं कुछ.
And this is typically a case of, okay, somebody else.
Dr. Tulsi, बताइए.
Yes, the proper examination of the patient is very important. As you told, it's a silvery patch kind of. So you have to always rule out is a precancerous lesion. That is always best for these patients. And after ruling out any some malignancy, you have to rule out everything. Then only you have to go after the examinations.
How you are going to rule out?
If it is a lesion, you have to always take a biopsy. If it is to rule out any precancerous lesion, we don't know what is it exactly, then we have to go for it.
So please describe how you will do the vulval biopsy. Anyone, how you will do the vulval biopsy?
It's a punch biopsy, man.
Yeah, we take a punch biopsy.
A punch biopsy.
Okay, go ahead.
Yes. Anyone.
May I comment?
Anyone.
So we take the punch biopsy from taking care that a part of healthy tissue as well as the unhealthy tissue. From the junction part, we take the punch biopsy and we send it for the histopathological examination. And after that, we start the treatment. The characteristic you mentioned, the silvery patch, the silvery white shiny patch on the vulva clearly dictates that it is a case of, most of the time, it is the case of lichen sclerosis, where there is severe itching, and after some time there is scarring. With the passage of time, the labia minora get vanished. They are most of the time fused with the labia majora, typical picture we are getting. And sometimes the clitoris also starts vanishing. The whole vulva becomes white, shiny white, silvery white, and it extends towards the anal opening also. So here the role of, after taking biopsy, the role of lasers as well as PRP is wonderful.
Do you supplement with the medication also?
Old treatment of steroids. Yes.
Dr. Poonam, do you supplement with the some treatment also? Dr. Tulsi, patient was originally yours. You tell me, if a diagnosis is made, you have taken the biopsy, it is come out a lichen sclerosis, which is a not so uncommon in the woman. And we as a gynecologist, we continue with the pessary and the things, and patient become a second grade lichen sclerosis, things become stenosis, then we come to, oh my God, this was a lichen sclerosis. So the patient came to in an early stage of the lichen sclerosis. What will be your counseling to the patient, and how you will go about this patient?
Ma'am, we'll also get an dermatologist's opinion on the same. And for the vulval itching, for the symptomatic relief, we might put her on, with a dermatologist's opinion, an and topical steroid like Tenovate cream, and all.
Please, no. I'm talking about the lichen sclerosis. I'm not talking about any infections or anything. And जितना हम लोग vulva
PRP
पढ़
also
रहे हैं,
helps, ma'am. PRP
it's
therapy
okay.
also helps.
Yeah, it will help. You are doing the PRP, you are doing the laser. It has give a dramatic result. In first sitting, patient will have a decrease itching, the redness will come up, but it is a chronic progressive disorder.
Yes.
It is not going to, it will come up. So you
Yes.
have to tell the patient that maybe you will go in the remission, but it will come up again. And the moment you will have, you have to come back. So these patients, you have to put on something like a steroid cream and immunomodulator. Because if you continuously you're giving a steroid cream, which is written most of the book, it will lead to a thin skin. And the time has come when we start treating our vulva. Don't give everything to the dermatologist and the urologist and the surgeons. And we are trying very hard since COVID to learn the vulva again, which at least I have never read properly in my PG. I only know about the Bartholin cyst. That's it. That is the vulva finish. So in those patients, normally what we do is a 15 days clobestrol, या mometasone, and the 15 days tacrolimus, that is an immunomodulator. How many patients you have treated? Any of you have really treated these patients? So I myself have 17 patient series. I'm a very poor person to write anything कि मैंने ये किया वो किया paper में. But and my husband is a dermatologist, so we compared also. If we didn't given the laser treatment to them, they are okay, they are fine, absolutely fine. But it took the time to suppress the symptoms. Their symptoms will go on. They have itching. It will take little time. But laser and the PRP, it is a wonderful thing, and that you have to continue and continue. So coming to next question, comparatively younger patient, corporate executive came to you and she's very, very depressed. And she said, Doc, when I was giving a talk to my whole team as a team leader, and suddenly I have a sneeze, and I was wearing a smart pant suit like a heroine, and there was a blob, and I was so embarrassed. Please help me. So how you are going to help her or not? Let me tell the examination also. She has no cystocele, she has no rectocele, she has no uterus descent. You cannot operate. You cannot put a sling because she's not pouring the urine. So what you are going to do? Give the Kegel?
Yeah, she's a case of stress urinary incontinence. She's having leak on sneeze. She told sneezing, and she's a young patient comparatively. So, in this case, it's a mild to moderate leak. That is what you are telling, ma'am.
Mild,
So in this case, always you have to go with the lifestyle modifications. Then the Kegel exercise is very important, and bladder trial is very important. You have to tell the patient to have proper hydration and pass urine at least 2 to 3 hours apart, and that will help the patient along with the HIFM chair, which can increase the Kegel contractions, the pelvic floor area.
So yes, I agree with your HIFM, but I don't agree with the Kegel. सारी जिंदगी से कीगल कराते चले आ रहे हैं.
People don't do it. We have to tell them.
आप उनको खुद भी प्रॉपरली नहीं बता सकते हो और वो उतने बार कर भी नहीं सकते हैं. And if you talk to the physiotherapist, the female rehabilitation pelvic physiotherapist, they will say that put that Kegel exercise in the dustbin, because pelvic floor is not only that particular muscles which are doing the Kegel, but it is a whole broad your pelvic floor, and there are many muscles, they need a proper exercise. And if you go to the list of the PFMT, it is really mind-boggling, but literally HIFM chair is a boon to all of us gynecologists. Tell our patient to sit on them. Any patient, they are coming with just a dragging sensation, backache, anything, everybody say, oh my God, what you have given me, doctor. After this chair, my life is really improved. Because that pelvic floor sags with the time. And specifically if they have a traumatic vaginal deliveries, even second stage cesarean, their all pelvic floor has gone. So now time is almost over. I just want from Dr. Anand, Dr. Reshmi, Dr. Varsha, Dr. Lakshmi, Dr. Aditi, whoever has joined, not my panelists, because they are in the field. Do you agree that you all should start practicing FRAG, that is functional regenerative and aesthetic gynecology? Dr. Anand, हम आपको पढ़ते रहते हैं, आप तो काफी ज़्यादा, I think, working in the field of the sexual medicine also. So दीजिए जवाब आप. पहले सबसे पहले आप, डॉक्टर रेशमी ने भी ऑन कर लिया है. Dr. Pavitra is also there. I really want a feedback from you people who are not working in that field. हम 5, 7, 8 लोग जो यहाँ बैठे हैं, are we doing a right practice or wrong practice? Whether it is a need of hour for the women or not, whether every OBGYN should know it or not.
In fact, in my opinion, cosmetic gynecologists should make the saying, love at the first sight, making practical.
Pardon, come again. Cosmetic gynecology तो मैं word ही नहीं use करती हूँ. I use a functional and regenerative gynecology.
Exactly. I'm
not talking about any cosmetic gynecology. Cosmetic gynecology के लिए हमारे पास कोई patient नहीं है. वो नहीं आ रहे हैं हमारे पास कहने के लिए बारबी डॉल बना दो मुझे और ये कर दो वो कर दो. I am talking about the URS sexual medicine practitioner. आपकी जो post आते हैं उनको देख करके. Women are suffering because of the vaginal laxity. It is a need of hour or not? You should address or not?
That must be corrected, you know.
Yes, that I'm not talking about only lasers and the PRP. I'm talking about the surgical part also.
Yeah.
If it is a very big gap, that is not going to correct it without the operation. A woman who is leaking very mildly, you cannot offer a TOT. Whether she should be treated or not?
She should be treated.
Ma'am, threads, peri-urethral threads we are applying, and this is giving wonderful results in mild to moderate cases of SUI. And thawed PRP, the newer technique, the PRP is put into the liquid nitrogen and then frozen, again thawed, then frozen, again thawed, and that PRP is injected into the bladder after emptying the bladder. Superb results are there in urge incontinence. So newer techniques, newer innovations are there in this, and the peri-urethral application of threads are actually giving wonderful results. We are doing. And we are preparing the data also.
Very good. There's a question. Carbon dioxide laser is contraindicated on the mucosal surface, but it is allowed. If there's a wart, you can cauterize, you can cut, you can do anything, but you cannot put it in the vagina. So it is FDA. Even in America, everybody is using. No, my dear, it is not cause any harm. If you have bought a machine, not for the 4, 5, 6 lakh, but a good machine which has a backing, and you're not going to do any harm to the patient. And as I forget the name who has said that, it is, I think Dr. Poonam has only said, the small, very small
Like hair follicle.
micro puncture is there,
Yes,
like a
like
micro aseptic burn, and it causes the regeneration.
they say that it's size of the hair follicle, that micro surgical.
This is not that ablative carbon dioxide laser which came in way back in 90s. It is not that laser. It is a micro pixel laser, micro ablative pixel laser.
And actually, now we use laser so much at a higher frequency and all that in hysteroscopy and laparoscopy. And what laser we use is much less, which is not at all harmful.
So before I finish off, and I will stop, then I want one line from everyone. There were a few questions. I'm just trying to answer that. Listen, there's nothing called 100%. A postmenopausal midlife woman has lost her estrogen. You are not producing estrogen in her body. So whatever you do, it is a temporary, it is a 70-80%. But you are providing something which with that they will go forward with a better life. And when it is again increasing, they have to come. If we get the Botox fillers on our face, every 6 months we go and get it done again. And the fillers every 16 months or 18 months. So it is no magic wand, no 100%. जो चीज चली गई वो चली गई, आप उसको सिर्फ जोड़ के थोड़ा सा, but the time will come, the way there is regenerative therapy is coming up, the stem cell and everything, the time will come. Maybe we are able to regenerate properly, but the time is there. What we have today, it is never promise more to the patient and always say, yes, you don't have estrogen. We have regenerated. Again, when it will go back, will come back to us and we'll do. So over to Dr. Jamna, one liner from you, then Dr. Poonam, then Dr. Beenal.
I think all the gynecologists should incorporate themselves into this subspecialty and get trained, because they are the ones who are going to get all the patients to them. Only they have to select and start practicing. That is what I feel. And we will give a good quality of life to the woman, whether it is short term or a long term.
So Poonam, you are always for the innovation. Vaginal
Yes,
thread is
ma'am.
brought by you. And so what message you want to give? Poonam? I think
Yeah,
she's
we
not
all
there.
are born estheticians. We try
Dr.
to make every scar beautiful, every skin beautiful. So we are actually born estheticians. We just have to learn the newer skills, and we all gynecologists are the aesthetic gynecologists.
Wow, wonderful. Beenal, to you.
Yeah, what I feel is that probably this field is not for everyone. The awareness should be there with all gynecologists, but just as some gynecologists focus on endoscopy, some focus on infertility, there have to be a special subset of gynecologists who are focusing on regenerative and aesthetic gynecology, because then only the proper justice will be given. So that is what I feel, that it should be a different subspecialty in itself.
Yeah, absolutely right. I was talking about the awareness to the all, because the women come, every woman is not going to come to you or
Yes.
Dr. Gita. But if she is coming to Dr. A and she is aware, she can say, bhai, ऐसा कुछ available hai, you can go there. Because if I am not doing oncology, I will send to an oncologist friend. I am not doing oncology.
Right.
So now coming to Dr. Jita, then Dr. Tulsi and Dr. Sivani, one by one. Your
Yes,
message,
ma'am.
then we will say
You
bye-bye.
said yes. Awareness is essential because we all have to speak the same language. So when patient comes to another doctor, they should be able to say that, such things exist, and all of us should be supporting each other and saying that this is right. Otherwise, patient will get mixed signals and they'll think, okay, doctor is trying this treatment, but it might not be working. So all of us should start using the same language when it comes to, functional gynecology. Frag. Okay.
गीता की स्लाइड ने मुझे एक बात याद दिला दी, although it is not related with this. Way back in 97, when I came to Gurgaon, I did my first LAVH in Gurgaon. It was almost 26 weeks uterus. So patient went back to the native place, and after 7 days, I saw 3 men coming in my room. Doctor, हम आपका ये कर देंगे, वो कर देंगे, आपने मैं चीट किया. कहते हमारी डॉक्टर ने ये बोला है, इतनी छोटी सी चीट से इतना बड़ा यूट्रस कोई निकाल कैसे सकता है? तो मैंने कहा अच्छा एक काम करो, तुम जाओ अल्ट्रासाउंड करा के आओ. अगर अल्ट्रासाउंड में नहीं निकला तो जो जो तुम मेरा कर रहे हो जाकर के अपने डॉक्टर का कर लेना. So the same thing is here also. Any new thing which come in the market, we ourselves become the critics of the people who are trying to do something new. Thank you, Jita. To you, Tulsi.
Of course, in this era, we are all talking about the women empowerment. So with all these kind of modalities, the newer techniques, let the women be more empowered sexually, physically by all these things. Let them talk
Very
about it and let them get corrected.
Yes. Somebody has written very nicely कि हमारे लोग सोचते हैं कि वो सब औरतों के यहाँ साइकोलॉजिकल है, उनको कोई सेक्सुअल नीड है ही नहीं.
Yes.
So Shivani.
Yes, as everybody said that all the gynecologists should have a basic knowledge of as functional, regenerative, and aesthetic gynecology, and they should know that what treatment options are available, and if they come across such patients, they should be free to referring them to a specialist so that at least that woman does not suffer anymore and she becomes more confident and comfortable in her own skin.
सारे पढ़ा रहे हैं भाई, कहाँ सीखोगे? पूनम के पास चले जाओ. मैं तो बहुत सिलेक्टेड स्टूडेंट लेती हूँ. पूनम भी करती है, रिधि भी करती है, ये बच्चे भी करना शुरू कर चुके होंगे अब तक, सब बहुत दिनों से हैं. बीनल भी करती होगी, सब करते हैं. सो आई थिंक वी आर कमिंग टू द एंड एंड होप. हाय राजू. सो I think you people like this way of the presentation or you wanted a PPT? Give me the feedback. Next time I will make a PPT.
No, I think this is good.
It was nice, interactive.
Yeah.
Spontaneous.
तो थैंक यू. तो आज डॉक्टर नगर किट्टी आप हमें बाय बाय करोगे या सरिता बाय बाय करेगी?
Thank you, Ragini ma'am,
Thank you so much
really
everyone.
enjoyed the
We
interaction.
have 192 people till end. Thank you so much being here and listening us.
Thank you.
Carry one message. We are very happy.
Thank you, Ragini ma'am. If I may I say one thing? Today only in my OPD I had a patient who said कि पहले जब हंसती थी तो यूरिन हल्का सा लीक करता था, फिर खांसने पे करने लगा, अब बहुत ज्यादा करता है. तो as you said about this regenerative and functional branch, had she known earlier or the doctor she had gone to earlier would have known about it, so maybe she would have been treated better earlier. So as you said, we should have a knowledge and we should know when and where to direct our patients, whether we are practicing it or not. So
Yeah.
thank you. Thank you for a very
So
great
much.
time.
We have coming with the postpartum rehabilitation program. If you send your patient just after delivery, say after 3 months of the delivery for their vaginal rehabilitation, this type of the mild incontinence will be treated at that time only, and she will have a wonderful life.
True.
So thank you so much.
Thank you, everyone.
ICOG. Thank you, ICOG, for giving us opportunity. Parag, Sarita, and everyone. Thank you so much.
हमारी तरफ से भी thank you कर दो.
From all of us.
Thank you, everyone. Very nice panel. I'm listening to it quietly.
Thank you so much.
Thank you.
Bye-bye.
Bye.
Good night.
Thank you.
See you all in the AICOG Delhi. Bye.
Yes, ma'am.
Good evening, Rajan sir.
छोड़ सकते हैं आप?
Ma'am, shall we post the test link?
Yes, yes. Please, please, please.
Yes, please go ahead with the post.
अच्छा, post test होगा. मैं जाऊं? Bye bye. Because I have to reach to the hospital.
The test has started. There's a link in the chat box and also a scan code which can be scanned, and the timer is also started. We have around 14 minutes left. And 1 minute prior, I'll give a warning. as was asked. Thank you. Please unmute Rajendra sir. 1 minute left. Posters, I hope all have submitted. ICOG team, there are some problems I'm not able to submit. Dr. Gauri is writing. Please see. Make it. So ICOG team will look into the matter, whatever the problems are. I'm just reading the answers. So for the post test, what is the primary cause of the genitourinary syndrome of menopause? Answer is C, decreased estrogen levels. Question number 2, which of the following is considered the gold standard treatment for genitourinary syndrome of menopause for most women? Low dose vaginal estrogen therapy. The diagnosis of genitourinary syndrome of menopause is most commonly based on, answer is B, clinical evaluation, including patient history and physical examination. For patients with genitourinary syndrome of menopause who have a history of hormone-sensitive cancer, which treatment is considered the gold standard? The answer is vaginal lubricants and moisturizers. Question number 5. Low-dose vaginal estrogen therapy is the criterion standard for treating GSM in most patients because it, answer is D, works well for all patients, including those with breast cancer. Question number 6. Phenotypic changes at menopause include, answer is 1, increased fat mass and decreased lean body mass. Question number 7. Protein leverage effect refers to, answer is 2, enhanced muscle breakdown requires more protein. Question number 8. Vegetarian sources of protein in Indian diet include all except rajma, soybean, rajgira. Answer is 4, poha. Question number 9. Which menopausal women can start MHT? Answer is B, high risk for CVD. Question number 10. All are FDA approved indications for MHT except, answer is C, dementia. Question number 11. Which is an example of synthetic estrogen? Answer is B, ethinyl estradiol. Question number 12. Which of the following is the most notable clinical benefit of using transdermal estrogen instead of oral estrogen? Answer is B, reduced likelihood of venous thromboembolism. Question number 13. Standard initial dosing for commonly used transdermal estradiol patches begins at, answer is B, 0.025 milligram per day. Question number 14. Tibolone acts primarily through which mechanism? Answer is B, tissue-specific estrogenic, progestogenic, and androgenic metabolites. Question number 15. Which of the following symptoms is most effectively relieved by tibolone? Answer is C, vasomotor, mood, and libido symptoms. Question number 17. Tibolone is contraindicated in which of the following conditions? Answer is B, past history of breast cancer. Question number 17. A holistic approach to managing menopausal changes is easier with D, integrative care with multidisciplinary approach. Question number 18. When managing sleep disturbances with holistic context during perimenopause, what is often recommended as a first line offering? Answer is B, improved sleep hygiene and guided visualization. Question number 19. Isoflavones includes the following except, answer is comestans. What drugs will interact with isoflavones? Answer is all of the above. So thank you all for submitting the post-test. And if there are any queries, the ICOG will respond. Now I request Dr. Rajendra Nagarkatti for the vote of thanks.
Thank you, Dr. Aditi. It was indeed a wonderful day with excellent talks by all the speakers. So I wish to thank all the speakers for giving excellent talks. And there was a wonderful panel on I mean,
Cosmetic.
it's nowadays not called cosmetic gynecology. So I was using the new terminology of functional and regenerative gynecology, as Dr. Ragini was saying. So wonderful panel with a very interactive panelists, and I think even the questions were very nice. I think one of the questions there was a typing mistake. Even Dr. Aditi paused there, but I think still it's okay. But I think we have got a good response. I was even getting some questions from some of the. I was getting questions from some of the people that they could not send the answers. So we will see about that. This is not a very, I mean, it's not an exam or anything. So let's see how to proceed with that aspect for those who could not log in or send their answers. But once again, congratulations to the entire team of ICOG for this wonderful series of, I would say, uh, uh, certificate course on midlife management. And once again, thank you for making me a part of it. And thank you, Dr. Parag and Dr. Sarita, for involving all of us. A big thank you from the entire, I mean, all three conveners, myself, Dr. Anju, and Dr. Archana Dwivedi. Thank you.
Thank you, Dr. Nagarkatti. Thank you, Dr. Aditi. Yeah, thank you for managing so well. Big thank you to all of you, all the conveners.
Thank you to all
Yeah,
the
and
three
thank you for all the
coordinators.
delegates for logging in. I think it's been very nice. And look forward to seeing you in the next certificate course.
Yes, yes.
Thank you, ma'am. Thank you for
Thank you to
involving
all the three
me.
coordinators, Dr. Aditi, Dr. Madhumita, and Dr. Reshmi
Dr.
Banerjee.
Reshmi.
Yes, yes.
Yeah, and all the conveners, Dr. Anju couldn't join today, but Dr. Anju and of course Dr. Archana Dwivedi and Dr. Nagarkatti. Thank you.
Thank you, thank you.
Okay, bye-bye.
Bye-bye, thank you. Thank you, Aditi, for all the help.
Thank you, sir. Thank you for the opportunity. Thank you.